All right. I am calling this meeting to order. Good morning, everybody. Welcome. And this is our April Public Employee Benefits Board meeting. For the record, it's April 13th, 2023. And our meetings going forward are going to continue to be hybrid. Healthcare Authority staff will be on site as much as possible, and other attendees, both board members and the public, will have the option to attend on site here in Olympia or via Zoom. For our Zoom attendees, our opening slide has information about how to turn on closed captioning subtitles. And Tom McRobert is here in the room. Great to have you in person. Michaela's with us as well in person, so thank you. I want to do board member introductions. So we will go ahead and do the roll call to identify board members who are with us today. Monica McElmore.
Present.
Thank you. Harry Bossy.
Present.
Welcome, Harry. Elliot Weinstein.
Here.
Thank you. Kurt Spiegel. Kurt, you were a little... can you do a sound check one more time? We kind of got that. We see you.
Yes, present.
Oh, we got you now. Thank you. John Comerford.
Here.
Thank you, John. Michaela Dolman. You're here.
Present.
Thank you. And Tom McRobert.
Present.
Great. And as usual, Michael Tunick from our Attorney General's office.
Present.
Thank you. He's here in person for those of you listening in. And I'm Sue Birch. With board members attending both in person and virtually, it's helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members will also watch in case you use your Zoom's raise your hand feature to indicate you have a question. The public will have an opportunity to provide general comments at the end of the meeting during the public comment period, and there are times where we integrate in public comment throughout. Now, Dave Eisminger, you are going to present to us the overview of today's agenda. And go ahead, Dave.
Good morning, Chair Birch and members of the board. Dave Eisminger here. We'll start off with some minute approvals from this season's meeting minutes, and we're back on track to have meeting minutes right after the meeting that has occurred. We've also been meeting that goal of getting the audio files up within a week of the board meeting for the full audio file for the public. We have a few follow-up questions from the last board meeting, and then since we last met, the legislature has introduced budget proposals in both the Senate and the House, so Tanya will be back to compare the various budget proposals and describe what is happening as we lean into the end of legislative session in just under 2 weeks. Speaking of legislative session, the bills have been flying. A lot of bills have made it through the process. A lot are still very close to the final part of the process. Some of them have been signed, so Cade will be here to reveal the status of all. Then we're bringing back to the board 2 resolutions for action that were introduced at the last board meeting. So Stella will take us through that process. And as a reminder for the public, if you're attending for the first time, there is an opportunity during that motion process for there to be public comment specific to that resolution, the subject matter of the resolution, before a vote is actually taken by the board. That's in addition and separate from general public comment at the end of the meeting. Stella will then do a briefing on the annual rulemaking process that we like to bring to the board each year, just as an FYI before we begin those formal processes. We're going to follow up with some questions and a presentation about over-the-counter hearing instruments. Last board meeting, Sarah Whitley from Finance described some of the utilization history of hearing aids. We know that we're tracking some legislation, but we thought it would be a good opportunity to talk about over-the-counter hearing aids, what changed at the federal level, and just share some information about OTC hearing aids. We try to bring smart health updates annually to the board, and so that we're going to take the opportunity during this board meeting. And then round out, there's a couple more things. We'll have a procurement update from our section manager. Shauna Lang that will go over 3 of the procurements that we've been working on in various stages over the last year and a half. And then Ellen. Ellen is always going to be on the agenda. There's always something to talk about in our Medicare space, whether it's follow-up questions from prior board meetings or changes or ideas for the future. There's just many things, so we always will have her on the agenda for some various topics in that space. And then towards the end of the meeting, before public comment, Molly Christie will be coming and sharing some insights that relate to ideas and questions that have come up over the last year about, the classic question is, if X was changed in the benefit design for UMP Classic Medicare, how would that, or would that help with the direction of premiums, or help stabilize premiums, or possibly even lower premiums? So we wanted to bring back some of the insights related to some of those ideas, which have been studied before, but it's always good to do a refresh and share that information with the board and the public. And so we'll be sharing some insights that have come up in the last year. We'll end with public comment and be done for the day.
Thank you, Dave. So with that, I'd like to move us into our first agenda item, the approval of the February and March meeting minutes. Today we'll vote on the 2 sets of those meeting minutes from this board session, our February retreat and our March meeting. These minutes are in the new format that we're moving forward with, and any feedback would be appreciated. There'll be a vote for each set of minutes, and you will find these minutes behind tab 3, separated by the goldenrod sheets of paper. So let's begin. The first vote is for the February 2nd, 2023 board retreat minutes. Are there comments from the board? Hearing none, do I have a motion to approve the minutes as written?
So move.
Thank you, Tom. Is there a second?
Second.
Thank you, Michaela, I'm sorry. I'm going to get that right someday. All in favor say aye.
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 Are there any opposed? Our February 2nd, 2023 meeting minutes are approved as written. All right. Let's move to our March 9th, 2023 meeting minutes. Are there comments from the board? All right. Hearing none, do I have a motion to approve the minutes as written?
So moved.
Thank you. Elliot, is there a second?
Second from Monica.
Thank you, Monica. All in favor say aye.
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 Any opposed? The March 9th, 2023 meeting minutes are approved as written. All right. We're going to move into our March meeting follow-up. Again, Dave Weisminger, our director, has some follow-up items to share with the board to address some inquiries from earlier this board season. Dave's materials are behind tab 4.
Good morning, board members and Chair Birch again. I realize now that I'm liberally using the word March, since it also is some follow-up from the retreat, but bear with me there because it is this season. The first part of the presentation of these slides is about DCAP, or Dependent Care Assistance Program, a question that came up during the retreat. And so on slide 2, we have the question here, and just to level set for a minute, just to remind everyone, the Dependent Care Assistance Program is generally a pre-tax benefit under the cafeteria plan that the agency administers, and it allows an employee, this is not something that's eligible to anyone who is not an employee in our program, but an employee can do pre-tax deductions from their paycheck up to $5,000 annually to assist them in taking care of qualifying dependents. And so there was a little bit of questions and some refresh on the circumstances of those qualifying dependents. So the question was about, are DCAP claims appropriate to pay a family member for dependent care? And generally, we'll see the answer on slide 4 is that it's claims are not appropriate if the caregiver is the child, so you can't pay your teenage child to take care of your younger child. You can't generally the caregiver it can't be they're not a qualifying child or a relative of the employee. They can't be your spouse generally, and they also can't be a parent. So there are a lot of limitations on being able to essentially pay a legal or blood relative the ability to be a caregiver. So generally, that is not the case. Typically, the main purpose of the DCAP benefit is to allow a parent to or the employee either access to seeking work, actually working, or obtaining training for additional work, or to increase their qualifications for different types of work. But there are a lot of prohibitions from the IRS about having and paying blood relatives or other legal relatives of your family use of those funds for those individuals. We also have included a link on slide 5 that can get people additional information about DCAP benefits, and that takes you to our vendor's website, Navia Benefit Solution. So I'll pause for additional follow-up, and I'm worried that maybe I misunderstood the question. Michaela?
Just a follow-up question. Does a person need to be legally authorized to work in the United States to receive payment?
Oh, that is a great question, Michaela. I don't know the answer off the top of my head, but we can check on that. I have a suspicion that we all probably suspect the answer is yes, because IRS, being the IRS, and checking on qualified status, but we can also follow up on that.
This is Sue Birch. I do want to clarify, DCAP is specific for this. These comments are so specific for DCAP. There are social programs that we have offerings in under certain waivers in the state design where other services are available where family members can be paid. So I want to just say publicly, this is so specific to our PEB program.
That is correct, Sue. Thank you for that. The next part of the slide deck is related to comments that Ellen Wolfhagen gave at the last board meeting, that the agency had provided some comments on a public rulemaking that was open in late December to early February on Medicare Advantage plans. And so on...
Excuse me, I had questions about the previous thing.
Oh, okay. I'm sorry, Elliot. Go ahead. You had more questions about
No,
DCAP.
it's okay. Number one, I could not hear Michaela. I don't know about the other people online, but I could not hear her. Maybe there's something wrong with her mic. I don't know.
If I talk like this?
Pardon me?
No?
I have
Still
the same
no?
problem. Thank you for raising it.
We're going to do a sound check. Michaela, can you
Test. No?
Can
Nothing?
you hear that at all, Elliot?
Hello?
Could you try again, please?
I think I'm trying and it's not working.
We're gonna swap out microphones, but maybe try Tom's. Can you reach over and just try?
What about now? Can you hear me now?
Yes, you have a soft voice. That's okay. So do I. But yeah, sort of.
All right, I will speak louder.
That's great.
Okay.
Thank you.
Thank-
That was basically my question.
Okay, thank you. We will proceed back to the CMS updates. Go ahead, Dave.
And just in case it wasn't captured, Michaela's question was about whether an individual to be eligible for DCAP funds needs to be
Lawfully.
a lawful, legally authorized in the United States to work. So we'll be checking up on that. Moving on to the CMS part. At the last board meeting, there was a request for access to information on the rules that were proposed by CMS that were subject to rulemaking from mid-December to mid-February. And so on slide 7, we've included the link that takes individuals to the, depending on how you print it, it can be anywhere from 300 to 500 pages. I personally print a little bit bigger font, and it made it 500 pages. But the extensive rulemaking, we wanted to provide access to that link in the materials. And this raises an important point that we learned in the last month or so. For some reason, when we send out emails, some people are not getting them. So we've been trying to check in with the board. If you are not receiving emails, especially in the Friday or Saturday before a board meeting, please reach out to me or Jessica. Jessica's also trying to do some spot checks, but several people did not get our information in the last month. And so we want to make sure that people are aware that we are sending things, but we wanted to include this link for the general public as well. And that's all that I have as the initial follow-ups. We are still working on a variety of presentations for later this board season, including there was a request from the board and public comment, I believe in January, about the pharmacy process from a member of the public, Linnea Mulder. We are working on a presentation for later this board season related to that, and we're also working on some information about the pipeline for when the FDA approves a drug to it being included in plan formularies. So just wanted to be, those things aren't lost in the shuffle and they're being worked on. Back to you, Chair Birch.
Thank you for that, Dave. Let's go ahead and move on to our next agenda item now. It's the 2023-25 budget update. So our very own Tanya Dool, our finance manager from Financial Services Division, is going to provide an update on the latest with the biennial budget proposal introduced recently in the legislature. Good morning, Tanya. Her materials are behind tab 5.
All right. Thanks, Chair Birch, members of the board. For the record, my name is Tanya Dool, the ERB Finance Manager, and I'm here to give a quick update on what we're seeing in the budget so far. I was here back at the retreat and gave an update on what we saw in the governor's budget, but since then we have now seen both a Senate and a House proposed budget, so I'll walk through a comparison of all three versions of the budget. The first thing we'll look at is the funding rates. I do want to take a second and back up because we do have a couple newer board members, and I apologize if this is known, but just what is a funding rate? The funding rate is an amount that is paid for every eligible employee per month to HCA by state agencies and higher education institutions. This amount is intended to cover the employer's share of medical, dental, vision, life, LTD, as well as our administrative costs and any impacts on our surplus. So if there's a surplus position, the legislature can choose to buy down that funding rate. If there's a deficit, they can increase that funding rate to fill that gap. So the indication of a funding rate level is not meant to say we're either reducing or enhancing benefits just on its own. So I just wanted to give a little history there. The three versions of the rates that you're going to see on the next slide are adequate to maintain current levels of benefits as well as a few decision packages. So on the next slide here, you'll see a comparison for fiscal year 24 and 25, the two fiscal years covered within the next biennium, for the governor's proposed budget, the Senate, as well as the House. Like I try to remind every season, there's no magic number here. There's no perfect number that we want to see here. We do provide models with recommended numbers for the governor as well as the legislature to use as a starting place for the funding rate. However, there's a lot of underlying assumptions that can lead to different funding rates and still cause no significant concern for HCA. So all three sets of the numbers here, there's no significant concern, but what you will notice is there is a change between the governor's and then the House and Senate versions. And that is because we delivered an additional model update between the release of the governor's budget and the release of the Senate and House proposed budget. Each quarter we release an additional model update that includes updated claims experience for that quarter, as well as in updated enrollment and any other administrative things that might change during that quarter. So you'll notice a difference between the governor's and the House and Senate, and that is due primarily to the updated favorable experience we had in that quarter.
Oh, yes, hang on.
John or Harry, I think that was, could you please mute yourself? We're picking up background noise.
Okay. Any questions about the funding rates before we move on? All right. So on the next slide is the value of the Medicare explicit subsidy. This is the amount that is for each Medicare eligible retiree. The amount that is reduced on their premium. So it's set at $183 in the all three versions of the budget, which is maintained from the current calendar year 2023. And this is $183 or 50% of the premium, whichever is less.
Tom. I'm a little unsure of the protocol here. It's been
Yeah,
so
no
long.
worries.
So I do have a question. How many years has it been $183? Is this the fourth or fifth year?
This, I believe, this will be 2024, or will be, I believe, the fourth year. But I can confirm that in just a second for you.
Okay, thank you.
Yeah, it was 168 prior and then 150 before that.
Yeah, I feel like it's, I apologize. I feel like it's been 3 years and we're going into the
Fourth year,
So
I believe.
We'll double check that for you because it used to be 168 or 160.
It was 168 prior for one single year and then was 150 prior for quite a number of years.
Tom, it definitely has changed during my time here, so we'll get that specifically. Any other questions on the explicit subsidy?
I think Elliot has her hand up.
Oh, Elliot. You're muted, Elliot.
It may be just me, but still, Tanya is kind of coming in and out, as far as when she speaks.
We'll do a sound check.
Tom and Sue are the only ones whose words are not garbled by the system. Just thought you should know.
Okay.
But secondly, on the next page, when you talk about it, could you explain what TPA is? I think I've heard it a million times, but I can never remember.
Yeah, no worries, Elliot. Is this better on my voice? Can you hear me clearer?
Yes.
Okay.
Much better.
All right. I will definitely clarify what TPA means, but I can also confirm, Tom, plan year 2020 was the first year of the explicit subsidy being at $183. Our intuition was right. All right, next slide, please. So these are 3 items that were similar between the governor, the Senate, and the House proposed budgets. The first one is TPA spending authority. And to clarify what that means for everybody, including Elliot, TPA is our third-party administrators. For our self-insured products, our medical product, UMP, and our dental products, UDP, the Uniform Dental Plan, we have TPAs, third-party administrators, that we pay to help administer those plans. Does that help, Elliot? Regents for UMP, Delta Dental for UDP?
Yeah.
Okay, yeah. So each year you'll see me mention TPA increased spending authority, and that is just each year as we have increased enrollment within our self-insured products, we have to do an increase to our budget in those accounts to spend the administrative costs. So we have a budget decision package for $2.2 million over the next biennium that was funded in all 3 versions of the budget. Next up, we have 1 FTE within portfolio management for the support of VEBA, which is the Voluntary Employees Beneficiary Association. I see Dave coming off mute.
I'd just like to take this opportunity to remind people, when you see 1 FTE and $316,000, that is not the salary of 1 FTE in the state of Washington. There are many different components of that. That's also not an annual amount, it's a biennial amount. So
Yep.
it represents 2 years. It includes everything from salary and benefits to infrastructure cost, IT investments. I just think it's always important to remind everyone who is not as familiar with these numbers that is not the salary of a single of this one staff member.
Great comment, Dave. And then next up is standalone vision. And what this is HCA had a decision package request to carve the vision coverage out of the medical plans into a standalone benefit. And for employees, this was set up within the bargaining agreement as a 100% employer paid benefit. So starting in plan year 2025, the vision benefits would be carved out of medical and be a standalone vision, similar to what exists within the SEB program.
However, just to clarify, and there will be a lot more of this as we go forward in the next board season, this would only be in the non-Medicare space.
Correct.
We would not be, the proposal does not include carving out the vision from the Medicare benefits because of various interactions. It just makes it a lot more complicated. So this is on the non-Medicare side. This is one of the kind of structural differences between the PEB and SEB programs right now. The SEB program launched with a standalone vision. We had done a procurement in 2020 to be able to offer those standalone benefits in the SEB program, and we made that procurement in a way that could be leveraged for the PEB program if ultimately there was going to be an alignment. And as you can see, there is a savings associated with it, so it is more efficient to have a standalone benefit than an integrated benefit, which is how this all got teed up as a future action. So we'll be bringing more to the board towards implementation of this in the future. Back to you, Tanya.
Yeah. Tom?
I know I've raised this question a number of times. There is some confusion with Delta, dental, and uniform dental Delta. And I noticed that we don't say uniform medical regents. So is there a way, I mean, maybe this is just a proprietary thing, but is there a way to just drop the Delta piece of that when people look at it, like you do with regents?
Tom, we can certainly try. One of the challenges we have is people associate one or the other. We're right now, Jean can probably attest to this, and Ellen as well. In our listening sessions, many people say I have regents. They don't say I have UMP. Same thing happens in the dental space where people say I have Delta. They don't connect necessarily with UDP. Some people connect with one, some connect with the other. We can do our best in our marketing to only focus on one name, but it's so pervasive in both of these plans have been around for decades, and so it's just kind of ingrained in individuals as to what sometimes they associate with the TPA, and sometimes they associate with us. So we're doing our best. I will say one advancement that we've made that just started printing recently is our explanation of benefits, and our uniform dental plan didn't used to have uniform dental plan on them. It had no indications that it was a UDP claim. It all said Delta. And that was actually brought to our attention in correspondence from a member of the public. I have to say, when that came through and I read it, I went, no, that can't be true. And I picked up my own EOB that I got the day before, and I was like, oh my gosh, this EOB doesn't even say our plan name. And so we charged Delta with administering that, and they recently revamped the EOB to make sure that there are indications that it's UDP. So we can do our best to try, but there are going to be people who associate with the carrier or the TPA name no matter what we do.
All right. Anything else on the proposed budget similarities before we get into where things diverge a little? Okay. Next slide. This is where things differ a little bit since the governor's budget. Both the House and the Senate have a proviso in there for $78,000 for implementation of Substitute Senate Bill 5696 and Substitute House Bill 1804. This would allow retirees or disabled employees of county, municipality, or other political subdivision, those groups that contract with PEB for benefits, those local governments that enter a contract to be able to participate in PEB benefits. If those contracts were to terminate, this would allow for their retirees to stay on PEB benefits. The $78,000 is just for implementation costs. Cade will probably speak a little bit more about that in his presentation coming up. And then in the Senate budget only, there was a proviso for $500,000 for a Medicare report. This would direct HCA to provide the legislature with a report that includes the findings from our listening sessions, as well as an analysis of a government self-insured plan with benefits that are equal to or richer and with more affordable premiums than Uniform Medical Plan Classic Medicare. And then additionally, in the Senate budget, there is some proviso language that directs HCA to consult with OFM regarding the consolidation of the PEB and SEB administrative operating budgets. This is not meaning consolidation of the programs. This is just technically how we would manage the budgets. Accounts would still be separate for PEB and SEB. It would just allow for us to have one single program for budgeting purposes, but accounting would still be separate for the two.
And thank you, Tony, for clarifying that it's not a direct indication of consolidating the two programs, but it is another part of that journey. That I've said many times, there are a lot of ways to consolidate the programs, and that consolidation word can encompass IT systems, it can encompass benefit designs, it could encompass the board, it could encompass administrative accounts. We're seeing a lot of different activity doing things that continue to make the programs more and more similar, and this is just another indication of that.
Next up was the last piece where things were different. You'll remember last season, Ellen had a lot of conversation with the board about dental benefits and the enhancements that the board would like to prioritize for the dental offering. We did do a decision package here at HCA with the items listed under the proposed benefit change column included in our decision package with the incremental costs. While the governor's budget did include two of the smaller items, both the Senate and the House did not fund anything from our dental decision package. So Likely in the conference budget, you will not see dental funding for PEB. Like Dave mentioned earlier, we only have a couple weeks left of session. April 23rd is scheduled to be the last day, so I will be back in May with a final conference budget. Elliot, I see your hands up. You're on mute, Elliot.
I do have a question about what, if any of you know, how come, I mean, I know it's money, but how come those two reasonable proposals by PEB were not accepted? Is there anything you folks know about that?
Elliot, we're still trying to explore understanding all of the thinking behind. You're correct that those two components there are relatively small expenditures. We're not quite clear on all of the different reasons as to why those could or weren't necessarily picked up. So we can report back as we get a little bit more of an understanding. Sue, is there anything you want to add?
Well, and Elliot, I would just comment that there's a lot of discussion about equity and parity. And so I think oftentimes people look at the richness of benefits or look at just, what the variation is. And I think there's obviously lots that has been pushed forward in the House budget that is creating strains and whatnot. So I think we're in an environment where I think people are also worried about an economic slowdown and just overspending writ large. So I think those are contributors. It certainly is some of the background chatter that I'm hearing.
And one of the other contributors, I think, is there are substantial investments that are being made to the PEB program. Tanya has highlighted at the board retreat this concept of shifting from the state index rate, that tiered weighted average process, to an employer medical contribution, which is benchmarked off of UMP Classic for establishing the employer contribution for purposes of the collective bargaining agreement. That is a substantial investment into the PEB program. So that could be another piece of the puzzle, is the legislature looking and saying we're putting multiple millions, tens of millions of dollars into the overall program related to that particular shift in employer contributions in the CBAs. That also could have been a very important piece of the puzzle.
Thank you, that is very helpful.
Other questions for Tanya? Not seeing any. So thank you very much for that update. Let's move on to our next agenda item, and it goes hand in hand with Tanya's information. So next we're going to be hearing from Kate Walker on the legislative update. Kate is our Policy, Rules, and Compliance Section Manager in our ERB division, and he's going to provide an update on the bills we're tracking in the 2023 legislative session. His materials are behind tab 6.
Thank you, Chair Birch, members of the board. Happy to be here again to talk about the current status of where we're at with the legislative session, which we are rounding the corner towards the finish line. Session ends April 23rd, so we are looking forward to wrapping up the session and getting into the fun part, which is getting everything implemented and tracking everything that we now get to do as a result of the session. Next slide, please. So just a quick, I like to include this one with each of the presentations just to make sure that it reminds me to give a shout out to all of our analysts that we have that work every session. This is other duties as assigned in their job requirements. So the analysts that we have within ERB and in the other divisions, this is other work that they do during session. And this chart represents hundreds, if not possibly thousands of hours of work being spent in reviewing legislation, analyzing it, connecting with stakeholders, connecting with our contractors, and reviewing, and a lot of reviewing and conversations and the like. So we want to make sure I give a big shout out to all of our analysts that work tirelessly to get these things done timely and professionally, and a lot of expert hours in here. Also shout out to our fiscal team, Tanya and her team. You can see here we've had over 80 fiscal notes this year, which is a pretty high number of fiscal notes, which is another significant amount of work. So a shout out to her team as well for all the work on making sure the budget is in line with the needs of our the legislation that's being proposed. So thank you to all of them. Next slide, please. Here's our tracker on how a bill becomes a bill. This is It's about accurate. This is a couple weeks old, but I think there's only maybe a couple of bills that have moved differently. This is where we're tracking through the entire process of cutoffs of the pieces of legislation that we identify as a high priority for the division, and where they are moving through session through the different cutoffs. So you can see here we are yesterday was the cutoff for making it off the chamber floor. That's not right. It's opposite chamber floor. Yeah. And then getting conference to the governors by the 23rd. So 8 bills, I think we're actually up to 9 bills have actually made it to or are on their way to the governors for signature, which is a pretty good number of bills that we track that are, again, these are high priority ERB led bills. There's a lot more legislation that has obviously made it through the session. These are things that we track that are very specific to ERB or have very significant impacts to the division, to the PEB and SEP programs. Whether they have financial implications, administrative implications, rule or policy making implications, that we are the prime analysts on for the division. So a lot of good work that we have to do with the 8, 9, 10 bills that we will have that will cross the finish line for us. Next slide, please. Just a quick update on some of the requested legislation. The agency as a whole had submitted Senate Bill 5700, which was largely a cleanup piece of legislation for all the different consolidation of statutes that have occurred over the last few years, cleaning up and synchronizing the language and removing outdated aspects of statute that didn't need to be in there anymore. That has passed. There are some components in there that pertain to ERB sections that, again, have no policy implications but are merely cleaning up the language, making sure we have the proper pronouns being used in it and that our definitions are all in alignment. That has passed and been signed by the governor, and it doesn't have any real implications for us to do additional work. It just makes our statutes a little bit nicer to read, which I'm always a big fan of. Writing statute cleanly is a challenge. Reading statute is even more challenging at times, so I like that we have spent the last few years putting a lot of effort into making our statutes a lot less horrible to read, I guess is a better way of saying it. Senate Bill 5421, while not necessarily agency specifically directed or agency requested legislation in the traditional sense, it is legislation that we drafted pursuant to CMS regulations that came out late last summer that didn't allow us to pursue the regular course of action for drafting legislation. But we were able to get this legislation passed that's going to allow for a new exemption in the Public Records Act that will exempt from disclosure all of the enrollment information that we collect for the PEB and SEP programs from being disclosed under the Public Records Act. So this is a really great piece of legislation that's going to help provide additional protection to all of the information that the PEB and SEP programs collect. That does include retiree information, which was really the crux of the bill being put forward in the first place, but it made sense at the time, and it made sense for us to include the entirety of the programs, not just the retiree information that we were collecting pursuant to CMS regulations. The result of this legislation passing and now having been signed by the governor is that we're going to be able to explore enhanced avenues or additional data that we can start collecting through our enrollment processes or through the launch of Benefits 24/7 in a few months that will allow us to collect race, ethnicity, language data with that added layer of protection that we can offer to members, that information is not going to be subject to disclosure under the PRA. And what that will allow us to do is really start getting into analysis on health equity issues, which is something that I think we are extraordinarily interested and excited about being able to move forward on. As a part of a work group pursuant to collective bargaining with the SEB program, we have been looking at issues of equity and our eligibility on the SEB side. One of the major barriers we identified was the protectability of that information if we were to start collecting race, ethnicity, language data. And so it was a happy circumstance when CMS required, I wouldn't say it was a happy circumstance that CMS required it for us, but we were going to take the circumstances we had and turn it into a real positive for us, that we now have this protection of that work in collecting race, ethnicity, language data, and really the work in addressing health equity in our programs is going to take a major leap forward with the passage of this bill. So very, very excited about the work to come on that. And Dave?
Yeah, I'll just add, this actually ends up protecting information that a lot of people assumed was already protected. There's this interesting space between, the healthcare authority sometimes is an employer, sometimes it's a plan sponsor, other times it's a program administrator. Some of this information, depending on which angle you're looking at, may or may not be protected health information. The agency typically isn't the employer of the 750 employers that we have, so while something might have been protected if it was in Michaela's personnel file, which she appreciates as state HR director, that same information wouldn't have been protected just because it's in HCA's file. And so this really kind of closed some of that loop because we aren't having an employment record. So, it's things like social security numbers, what plan your enrollment in, the name of your child dependent, any of the documentation that a member provides to prove dependent verification and eligibility, all of that now will be exempt from public disclosure. So I think that this really meets a lot of people's expectations. It was just a potential gap in our clear authority to exempt this, and it really just nips all that in the bud. And as a recovering lawyer, and Kate gets to stay a lawyer, it's always great when you can eliminate risk entirely. Very rarely can you say that, but this eliminates that risk and allows for the exemption.
And the lawyer in me would say, I'm not sure it reduces risk entirely. That would depend on a lot of other things, but I'd say it's a great step forward in us being able to start that process. And I am confident that we'll be back in due time to talk about the efforts we have in collecting data and our health equity work in conjunction with our the pro-equity anti-racism work that the agency is engaged in, that I also have the privilege of working on. Next slide, please. Oh, yes, please, Michaela.
For Senate Bill 5421, is there, or I guess related to that, is there any movement around collecting gender demographics, specifically around like kind of non-binary gender demographics?
I think all options are on the table now for us to be considering data fields to start collecting. This really allowed us to lower that barrier that we saw as David described, about just the uncertainty about what level of protection we could assert over that information. It was never challenged up to this point. And I'm glad it had not been challenged up to this point, so we weren't having to really ferret out if this is how much of a problem it would be. But now that we have this in place, it really does open up a lot more opportunity for us to explore what fields of data should we be collecting to be able to accomplish different things and helping to assess where the program can work on fixing inequities or other deficiencies that exist.
And this is Dave. Our agency has been on a multi-year journey related to being able to allow members to provide answer gender questions with multiple options besides just male and female. I'm not sure exactly where we are on the journey. At one point, we've looked at changing our forms, then we're capturing data within our systems, and then the final part is pushing that to the carriers, and the carriers actually using it for something. So we have been on a journey of that independent of this. I believe we're at the point where it's in forms and we're starting to collect that data. I don't think we're quite yet to the point of pushing for use by the carriers. But that is a multi-year project that our agency's been on for all of our populations, not just the PEB and SEP programs.
Yeah, and I want to add, it's not just multi-year, it's multi-agency, because it became an edict about being able to more accurately offer choices around gender.
Thank you for the question.
Elliot, do you have a question?
Yeah, I'm not asking anybody to repeat anything, but I couldn't hear Michaela, and I think sometimes you're talking to each other, which is great, but the mic you're not talking in front to the mic, and I can't hear you.
Thank you for that feedback, Elliot. I can just attest that Michaela is leaning in and right at that microphone, so we'll just ask her to keep amplifying. But the state, just to restate, the state has had significant IT transformations underway and has won many awards around gender accuracy and just the IT system supporting that. So
Thank you.
let's proceed, Cade.
All right. And just to check, I'm coming through loud and clear? I've never been accused of not being very...
No, I can hear you loud and clear. I can hear Dave and Cade and I'm sorry, the men. I can hear the men. I can't hear the women. That makes it easy.
Okay. Well, here we continue. All right, on to our topical areas of legislation. Senate Bill 5275, this has been signed by the governor. It grants the ability for the SEB program to allow certain employer groups to join on a voluntary basis. Those employer groups being the organizations that represent school employees such as WEA or PSE. It allows for tribal schools to contract with SEB, and it also allows for the board members of school board members to participate in the SEB program. It's mirroring what is currently done in the PEB program. It further expanding access to be able to use our benefits on a voluntary basis for those employer groups. We also have Senate Bill 5490 has been passed and signed by the governor. This is creating now what we're referring to as the nibble at the apple for a very small select group of retirees that meet a narrow criteria to be able to return or to join PEB retiree benefits. That criteria is very narrowing from the entire scope of the population that might be eligible to rejoin PEB retiree coverage, requiring that they had been denied to return to PEB coverage due to a failure to submit the retiree deferral form. They had to have then appealed that denial to our Office of Legal Affairs, and they must have done that by December 31st of last year. And they also must be Medicare eligible, as the legislation restricts their ability to enroll into a Medicare Advantage plan only, meaning they're not allowed to enroll into any classic Medicare plans. That has passed, and Medigap too. That has passed. It has an emergency enactment provision. We are currently underway in implementing it, drafting emergency rules, working on communication, data strategy to try and identify this population and have direct outreach to them, and having other communication strategies. I will be back next month to talk more about the implementation efforts of all the legislation that we are underway. This is just very early, and we're on it right now, and it's a bit of a whirlwind. So thank you to the team that's helping in that whirlwind effort to get that implemented. House Bill 1008, this is a nice little clean piece of legislation that has a really great impact for the retiree population or the retiring population. It expands the definition in our statute of what a separated employee is to include those who are enrolled in Plan 2, PERS, SERS, and TERS plans through DRS. What the effect of that is that now the members who are in Plan 2 that separate from state employment prior to drawing their pension, prior to Medicare age, are eligible to enroll in the active risk pool as a retiree without having to be drawing a pension. This has been available to the Plan 3 members in PERS, SERS, TERS, PSERS for quite a while now, and it just expands that definition to allow those members to join the retiree benefits earlier than when they begin drawing their pension, which is typically a requirement for them to enroll in retiree coverage. Not a lot of implementation effort will be necessary in that. We'll just be changing our rules and policies and forms, and a whole lot of work from a little bit of a definition change, but it will have a good positive impact for the population. Moving on, companion bills 1804, no, back to the prior slide, please. 1804, 5696, one last little bit of legislation regarding retirees. This is again addressing a rather narrow group of the population has been negatively impacted by the way the program has just evolved, where when employer groups in the PEB program that leave the PEB program and have retirees that are in the retiree population, those retirees are oftentimes, they are given a small window of time where they're allowed to remain in the retiree program, but then after 18 months they're no longer allowed to stay when their employer group is left. What that has resulted in is a lot of these retirees from employer groups like health districts or cities, counties, other municipalities that are voluntary participants in PEB, is that the retirees are left without coverage, or they're left with a very limited options that are extraordinarily expensive for themselves. And so legislation was drafted by Senator Robinson with our assistance, as well as Representative Steele, to allow the retirees from employer groups to remain with the PEB retiree coverage in a non-subsidized payment scheme when their employer group leaves. Now, it will also allow for the retirees who have been negatively impacted by this so far to return to the program. They have a window through the end of the year to return to retiree coverage with the PEB program. And then it also imposes on any new employer group that joins the PEB program, and really it will also impact the SEB program as mentioned above in 5275, which now has employer groups going into the SEB program, that those employer groups that join after the legislation has been signed, that they will be subject to a lump sum surcharge that is the amount of the implicit subsidy for their non-Medicare retirees until they would become retired. Medicare eligible. What that means is that there would be, for any of those employer groups that were to join after the date of the bill, that if they then leave afterwards and they have retirees, they're going to remain, there's going to be a big chunk of money that they need to give us to make sure that it offsets the implicit subsidy that's available by the nature of participating in the active risk pool for their non-Medicare retirees. That's a whole mouthful. It doesn't have a significant impact on the program itself. It will have a lot of impact on any employer groups that join in the future, because that will have to be something they take into consideration upon joining, and we will make sure that that's spelled out for them and have the kind of the cost estimates for them to be able to do some of the math for themselves when they start contemplating participation. So we will see the employees that lost eligibility, they'll be able to return immediately once that, I think the legislation has passed both houses. I think they're just getting a conference bill put together on it, and then it will go to the governors for signature, and that emergency enactment clause will go into effect, and we will begin a similar process to what we're doing right now for 5490 for that component of the legislation. I'll pause there and see if there's any questions regarding any of the retiree or SEB legislation impacts.
This is Sue. I'll just comment that that last proposal really demonstrates the state's commitment to keep people covered. So that surcharge, I believe that it'd be interesting. I bet that's a first in the nation about that movement. It'd be interesting to understand that a little bit more, but really smart public policy.
Agreed. Thank you. Glad to see. It's great to see. I'm excited to see where we continue to go with expanding the access of our really great PEB retiree benefits to more of the population. Next slide, please. All right, so we'll go into some of the cost sharing. We've had quite a few pieces of legislation that are still moving or have passed or just right at the cusp of passing that will help reduce or eliminate certain cost sharing for specific services. We did see the passing of 5242 that eliminates the cost sharing for abortion services. House Bill 1222 regarding expanding the coverage for hearing instrument coverage. I do think that it's either passed both houses and has not been conferenced yet, or has things are moving very rapidly right now, so hard to keep track. Dave might know, probably knows.
Anything that doesn't have passed on these, with the exception of 1008 on the last slide, is still subject to one more vote in one of the chambers.
Thank you. And as well as 5396 on eliminating or reducing the cost sharing for breast exam services. Next slide, please. We did see the pass and signing of 5729, making the $35 a month for a 30-day supply of insulin signed by the governor. This is extending that cost limit, the cost cap that had been passed a couple of years ago, and again expanding that, which is great for all those who use that service, and $35 capped for that 30-day supply of insulin. So that's great. That's legislation that would be passed. Next slide, please. And the wrap up of things here. We did see the pass of the 5319 regarding pet insurance. The reason why we put this up there is because the SEB board does have explicit authority granted to it to provide optional benefits that include offering pet insurance to their population on a voluntary self-paid basis. We mention that because it's likely something that would not be outside the scope of reasonableness for us to then seek the legislature to grant that same authority to the PEB board to offer similar benefits or the same sort of optional benefits that the SEB board currently has. When we launched the SEB program, one of the things we had done is a survey of the school districts about what other optional benefits they offer to their population that weren't what we were going to be offering in the SEB program. And one of the top ones that we got back was actually pet insurance that they offered to their employees. So there's quite a appetite for a pet insurance product to be offered in the SEB side. 5319 makes it grants the Office of the Insurance Commissioner the ability to regulate pet insurance and create a regulated market in the state, which could then result in the SEB program deciding to study it and possibly offer it as a benefit to the SEB population, which could then transfer over here. Elliot, I see a question from.
Am I correct in assuming that this would apply to retirees as well in the program?
Elliot, I think it's safe to say that if there is right now there's no authority for the PEB program to offer pet insurance. Our thought process is that if there were legislation to grant that authority, that type of benefit, any benefit that isn't tied to true employment status, would be available to everybody in the population.
So a few steps to get there, but first step, getting it regulated on the market so we can review it as a regulated product. We also have House Bill 1357, modernizing prior authorizations. This could have an entire presentation on itself about the impacts of this legislation. It's gone through a lot of iterations. I'm not sure I'm perfectly clear on the current iteration of it, but it's working really hard for providing more transparency for consumers regarding prior authorizations, requiring carriers who have prior authorization requirements to amend those to to what the legislation is requiring. One aspect of it is looking at things like how often are you actually approving this, and if that approval rate exceeds 90-95% for a certain number of individuals who require that prior authorization, that it no longer should be requiring prior auth, or it should be a more streamlined process. Things like that that are all generally really good for consumers and for our members in that prior authorization system. I don't know, David, I don't know if you have anything else you want to add. It's a fun one.
The other piece that's I think will resonate with a lot of board members and members of the public is it seeks to shorten the timelines and turnaround times of prior authorizations in a variety of instances, and leveraging electronic prior authorization processes. And so it's kind of essentially setting new service level expectations of carriers, which will result in staffing increases at the carriers to be able to meet those turnaround times. So that's a significant piece. And I know that, again, that will resonate with a lot of you and a lot of consumers. Sometimes the time that a prior authorization takes is just an uncomfortable and stressful situation, and things that can shorten that timeline up are I think, welcomed by the consumer community.
Yeah, and this is Sue. I would just say that, again, this is part of the drive towards creating greater efficiencies and reduced administrative burden. But change is hard, and there's a lot of complexity in this. But I do think this is one that would be good to come back after there's certainty about what is passed, because this is part of the transformation of what needs to keep happening about reducing administrative load or burdensome processes that delay care.
Absolutely. I'll make sure I bring that back. Also, we've got our full slate of new or expanded licensures. I haven't crossed off things that haven't made it just because of keeping it up there, and we're tracking them, but not as terribly closely as other pieces of legislation. However, as a preview for the next presentation I'll provide, session will be over. I'll be breathing a little bit of a sigh of relief. I'm sure the agency will have a collective sigh of relief when we get to the end of session, and then all the fun work begins of getting things implemented and already preparing for next session as it is. But I will plan to provide an overview of all the pieces of legislation that has passed, what we may, what from the new and expanded licensures, what has made it through, what hasn't. Begin talking about the implementation efforts that are going forward and the work that we're doing on implementing the piece of legislation that have emergency enactments, which is a little bit of a new thing for us. We've not handled too many pieces of legislation in the last, I don't want to say about 10 years, that have emergency enactment clauses. So a little bit of a different process for us to be undertaking right now, but we're up to speed on it right now and doing a good job. Then we'll also talk about, I'll bring back 1357 and expand more on what 1357 offers. Although I'm certainly not the expert on it, I will provide everything that the legislation talks about when we have finality on that bill, assuming that it does pass. And then just a final wrap up of the session. So with that, happy to take any questions. Otherwise, I'll let the
Tom?
I just want to make sure, I have one question about the modernizing prior authorizations. So one of the complaints that I've heard is that providers have been asked to do increasingly a number of referrals that they have to do in a year, whereas maybe originally it had been one referral a year, then it became two, then it became three. Is this going to kind of eliminate that, and maybe it'll be limited to how many times you need a referral in a year?
Given the number of changes the bill's made, I wouldn't want Cade to commit yes
Yeah.
or no, but as he brings back the detail in 1357, we'll make sure that he highlights the absence or inclusion of referral limitations and refinements there. That isn't a topic that I remember in 1357, but I believe there's been at least 6, 7, 8 iterations of this bill, so it's really hard to keep up with the exact structure of it, but we will make sure to flag talking about referrals when Cade brings back the full detail on the final version.
Thank you. Any other questions?
I just want to remark on behalf of the board, Cade, you and Dave, this is your go time. You all are stewards of this legislative work. You've done an exceptional job. I want to thank you guys. I think forever now, Cade, we're going to refer to you as the steward of the clean statute goals. So thank you both, and please convey that to your team. I know we're not through it yet, but it has been a lot of work and energy this session, so thank you all.
Yeah, and Chair Birch, I'll just say it's really exciting. Usually, this is the first year that I remember having multiple pieces of legislation that relate to eligibility and enrollment policies that had serious consideration, and it looks like virtually all of them are passing in some way, shape, or form. So progress on some long-standing issues that have been brought either from the retiree community or by the agency. It's really exciting to see so much progress. There was a time when we had a cleanup bill that I think took 6 years to get through the legislature as an agency. So it's exciting to see so many active pieces being able to improve the programs.
Thank you, Cade. All right, board members, we're going to move on to our next agenda item. I'm just going to do a quick check, though. Do we need to do a quick stand bio break for those of us that have been chugging a lot of coffee, or could we just do, if we could just do 5 minutes and we will return, okay? That will be at 10:10. Just stand up, stretch, use the restroom. We'll be right back.
I wear them because my partner works at a hospital, so I just wear it for everyone else's sake.
Colleague said she referred to as a technical violation for which there is no.
Okay. I don't know that. I don't know. Figure out what
She's like, my battery's going down. She said, thanks so much.
So, if anyone ever asks, just leave it at that. So just know, like, if anyone thinks we're not doing that, so that's a so then we have to just kick it out. We can't put that in. Somebody turn on the microphone. Right. Turn, yeah. So isn't that amazing?
He's the knee
Isn't that fun? That's what we learned this week.
Thank you.
Take my phone off of airplane mode for 2 minutes. I just put it on.
Stella, I'm going to butcher your name. It's not Naime. Ing. Okay. Ing. Okay. I apologize. Ing.
Without the vowel, yeah. I just blame it on the grammar.
Just start with the end.
It's like,
Got it. I'll try.
if not English.
Beg forgiveness.
No worries. No worries.
Dave, I'm not sure I like the placement of that clock, but I'll try to live with it.
That's not where I thought it was going to get added.
Yeah, I bet it was like where we had a hookup or, it should be a battery.
There. Oh, it can't because of the wall.
Oh, what about that? Anyways.
Just switch seats with me next time.
No, they can't have there because of the cameras. It's getting increasingly tricky about all sorts of things. So. All right, everybody, we are reconvening. And my health and wellness coordinator is appreciating that stand break, so please feel free as you need to get up and get refreshments, stand, do whatever. Thank you. I know these meetings can get long. All right. We're going to move to our next agenda item on policy and rules development. Stella is our policy and rules coordinator in the ERB division, and she's bringing back 2 policy resolutions for a vote today. After Stella reviews each policy resolution with us, I'll ask for a motion to adopt and a second. I'll invite public comments on the resolutions. I'll ask for discussion from the board until we are ready for a vote. And Stella's materials are behind tab 7. Stella, welcome.
Good morning, Chair. Good morning, Chair Burge, members of the board. For the record, my name is Stella Ng, and the Policy and Rules Coordinator for the ERB Division. Slide 2, please. Here are the 2 resolutions for action today. The first resolution addresses when a subscriber has a change in residence that affects medical plan availability, and the second resolution addresses Medicare Advantage and Medicare Advantage with prescription drug plans involuntary termination. Next slide, please. This slide and the next slide are included in the presentation, so the board have them available for the policies we will discuss. Slide 5, please. I'm including this slide from the March 9th board meeting to provide clarity on the revised examples 1 and 2 for resolutions PEB 2023-01 when a subscriber has a change in residence that affects medical plan availability. Next slide, please. Based on Michaela's feedback at the last board meeting, we've revised examples 1 and 2 for resolutions PEB 2023-01 to address the subscriber will be enrolled in the most comparable PEB medical plan as designated by the director or designee. Slide 8, please. We received no concerns from stakeholders regarding these resolutions, but have questions or suggestions about how we would implement these resolutions. Are there any questions from the board?
Stella, I'm not seeing any. So I will go ahead and restate, and we will move to action. So we are going to take a vote on resolution PEB 2023-01 when a subscriber has a change in residence that affects medical plan availability. Resolved that after a change in residence, the subscriber must elect a new medical plan if a subscriber's current medical plan is no longer available based on residence. If they do not elect a new medical plan within the time period allowed by special open enrollment rules, the subscriber will be enrolled in a PEB medical plan as designated by the director or designee. Is there a motion to adopt?
So move.
Thank you, Tom. Is there a second?
Second.
Thank you, Elliot. Are there any comments now from the audience? And I'm looking here in the room and not seeing any hands, and I'm not seeing anything online. Are there any comments from the board? We are not getting any signals from the board. I'll move us into a roll call vote. Monica McLemore? Monica, if you come off of mute.
Yeah, sorry, I was muted.
Thank you. Is that a yes?
Yes.
Thank you. Harry Bossy?
Yes.
Thank you. Elliot Weinstein?
Yes.
Kurt Spiegel?
Yes.
Michaela Dolman?
Yes.
Tom McRobert?
Yes.
And this is Sue Birch. I vote affirmatively as well. Resolution PEB 2023-01 passes.
Next slide, please. The second resolution, PEB 2023-02, addresses when a subscriber is involuntarily terminated by their Medicare Advantage or Medicare with prescription drug plan. Unlike the first resolution, we received no feedback specifically regarding this resolution. Are there any questions from the board?
I am not seeing any, so we're going to again move to a vote. Resolution PEB 2023-02, when a subscriber is involuntarily terminated by a Medicare Advantage or a Medicare Advantage prescription drug plan. Resolved that when a prescriber or their dependent must be disenrolled by the Medicare Advantage MA plan or Medicare Advantage prescription drug MAPD plan, as required by federal law, the subscriber and their enrolled dependents will be enrolled in a PEB medical plan as designated by the director designee. The new medical plan coverage will begin the first day of the month following the date the MA or MAPD plan is terminated. Is there a motion to adopt?
So moved.
Thank you, Harry. Is there a second?
Second.
Thank you, Monica. Are there any comments from the audience?
For the record, Chair Birch, it was Kurt who made the motion.
Oh, I'm sorry. Thank you, Kurt.
Okay.
Thank you, Dave, for catching that. Any comments from the audience? It looks like we do have a hand raised, so one moment, please.
Aruna is the speaker.
Aruna, I'd like you to call on you if you could please unmute yourself and identify yourself and your affiliate and make your comments to the board, please.
My name is Aruna Buita. I'm from Spokane, and I'm a member of RPEC, a retired social worker. My question is, under what circumstances a subscriber would be disenrolled by the MA plan or MAPD plan?
There are a number of circumstances that the member will be involuntarily terminated by the Medicare Advantage or Medicare Advantage with prescription drug plan. For instance, if a member has a change in residence and do not make a plan change within the CMS guideline, then after 6 months, the CMS will require the Medicare Advantage or the Medicare Advantage plan to disenroll the member. That's one of the situations where the member will be involuntarily terminated. The other instance that we provided to the board at the last board meeting was the member who fails to pay their Part D IRMA to the government, and CMS notifies the plan to effectuate that disenrollment.
And Stella, can you remind people what IRMA stands for?
It's the that's a good question. So it's the income-related modified.
It's Stella. It's the income-related monthly adjustment amount, and I realize that Ellen Wolfhagen later in this board meeting is going to go over some more IRMA details.
Thank you.
But your point being that if IRMA is not paid, CMS requires disenrollment.
That's correct.
Thank you for that clarification, Stella. Are there other comments to come before the board from members of the public on this issue? Okay, seeing no other comments or hand signals, I would like to ask now, are there any comments from this board? We are not getting any indication, so we were going to move to a roll call vote. Monica McLemore?
Aye.
Thank you. Harry Bossy?
Aye.
Elliot Weinstein?
Aye.
Kurt Spiegel,
Aye.
Michaela Dolman,
Aye.
Tom McRobert,
Aye.
and this is Sue Birch, voting aye as well. The resolution PEB 2023-02 passes.
Next slide, please. So for the next step, we will issue guidance to the employing agencies regarding these resolutions, and we will incorporate resolutions into the PEB program rules.
Thank you, Stella. All right. I think we're going to continue to move on. Since we took our little mini break, and if we need to adjust and do another stand break later, we will. I see smiles from my health coordinator back there. The next agenda item is the issue of over-the-counter hearing instruments. Janice McAlpin, our senior account manager with the Uniform Medical Plan team in the PERB division, is here to give us some details.
Stella has a second presentation, Chair Birch, at the top of page 6 of your.
Oh, I'm so sorry, Stella. I thought we were done. Annual rulemaking briefing by Stella, who's staying with us, our policy and rules coordinator in PERB. She's going to go over that annual rulemaking briefing. I did that too fast. Sorry, Stella. That coffee caught up to me.
Not a problem. Good morning, Chair Birch, members of the board. For the record again, my name is Stella Ng. I'm the Policy and Rules Coordinator for the PERB division. I'm going to go over high-level information on this year's rulemaking and highlight the most significant changes and rulemaking actions we are considering making. No action is needed from the board for this briefing. Next slide, please. Here's the rulemaking timeline. These are some tentative dates as we are working on some parallel rulemaking due to legislation. So by June of 2023, we will file proposed amendment CR 102 and distribute new rules for public comment. In July, we will conduct public hearing and adopt final rules. So all of the permanent rules will become effective January 1st of 2024. Next slide, please. The focus of this year's rulemaking is divided into 4 different areas. We will implement PEB board policy resolutions that are passed by the board this year. We are drafting rules related to several bills that have passed during this legislative session. We're adding clarity to rules to better administer and manage PEB benefits as identified by staff and stakeholders. We are making amendments within healthcare HCA authority, and we are making changes to comply with federal requirements. Next slide, please. Under implement legislation, we are doing some cleaning up related to Anglo Substitute House Bill 2140 regarding non-represented educational service district school employees in the PEB program rules, as this population will join the SEP program effective January 1st, 2024. And Kay just went over the rest of the bills in his presentation extensively, so I will skip the rest of the bills as mentioned in this slide and the next slide and go over changes regarding administration and benefit management. Slide 6, please. Under administration and benefits management, we're adding a new special open enrollment regarding when the PEB program determines that there has been a substantial decrease in the medical providers available under a PEB health plan.
Stella, I just want to give some context to this one. It's no secret that there have been a lot of tense provider negotiations with various carriers throughout our state in the past couple of months, and it seems like a likely trend that's going to continue. And so we're just putting in place the ability for the agency and the program to run a larger scale limited special open enrollment opportunity in an instance if there is actually a broad network termination disruption that actually occurs. As we've said many times, when these disruptions, when those notifications go out, the vast majority of the time a resolution is ultimately reached and there is no disruption in the network. But eventually there's probably going to be one. And so we just want to have things in place to be able to reassure members that if a termination actually happens, that there would be an ability for the agency to run an open enrollment. It is carefully crafted so that the agency makes the determination as to when such a disruption happens. But this is just to put things in place for safekeeping on a rainy, hopefully never needed day.
And we are amending special open enrollment rules to add a notice requirement for an employing agency when an employee experiences an event that creates a special open enrollment event. Next slide, please. We're amending additional rules to implement PEB 2022-01 when employees returning to work from active duty. We are clarifying when the rule ceases to apply that addresses in situations where an employee moves from one position or job to another due to a layoff. And we are clarifying the Medicare Advantage and Medicare Advantage with prescription drug plans enrollment and disenrollment process. Next slide. Under this slide, we are clarifying the substantive eligibility requirement when an employee or a school employee must begin to receive a monthly retirement plan payment for enrolling in PEB retiree insurance coverage. And we are making technical corrections to clarify when a subscriber may enroll in PEB retiree insurance coverage or continue in a deferred status when they are no longer eligible for the employer contribution towards PEB benefits. Under amendments within HCA authority, we are amending to include an employer group notification requirement be sent to affected employees and former employees when an employer group ends participation in PEB insurance coverage. Next slide, please. Under regulatory alignment, we're amending to include details when an employee has a carryover amount from the medical flexible spending arrangement in the previous plan year and enrolled in a consumer-directed health plan for the following year. Are there any questions from the board?
Michaela.
On slide 6, do you have a definition for a substantial decrease?
We don't have a definition as described in the rule, so that will be determined by the program.
Michaela, I would just say it typically relates to networks or network adequacy or disruption. And Dave, we'll have to ponder that a little bit, but thank you. That's a great question. Other questions for Stella? I can't believe I just practically glossed over all those important little administrative rules, things that need to continue to be maintained and improved. So Stella, thank you for that presentation. Now we're going to move on to our next agenda item.
Thank you.
The over-the-counter hearing instruments. Janice McAlpin is our senior account manager with the Uniform Medical Plan team in the ERB division, and she's here to give us some details about the over-the-counter hearing instruments, which also will respond to the questions on this topic that came up at previous meetings. Her information is behind tab 9. Welcome.
Good morning, Chair Birch and members of the board. For the record, my name is Janice McAlpin, and I'm a senior account manager here at the Healthcare Authority. Today, I will be speaking to an overview of the over-the-counter hearing instruments, and I'll try to remember to keep this on. So on this slide right here, last year in October, the FDA issued a federal rule for over-the-counter hearing instruments. This federal rule established a new category of over-the-counter or OTC hearing aids, and that enables consumers with perceived mild to moderate hearing impairment to purchase hearing aids directly from stores or online retailers without the need for a medical exam, prescription, or fitting adjustment by an audiologist. So hearing aids that do not meet the requirements for the OTC category, so for example, because they are intended for severe hearing impairment or users younger than age 18, are prescription devices. Next slide, please. On this slide, you'll see a comparison between OTC hearing instruments and prescription hearing instruments. So in the middle column is OTC, to the far right is prescription hearing instruments. And starting on the first row, so for selection process, the main difference in selection process for OTC is that OTC allows self-selection, while prescription requires an assessment from an audiologist or hearing instrument specialist. Down to the next row for fit by, this is for fit specific. So prescription hearing instruments require, again, a licensed audiologist or a specialist, while OTC allows for self-fitting. And then on the last row for hearing loss diagnosis and severity, it's required to be diagnosed by a hearing aid exam and assessment for prescription devices. OTC hearing instruments allow and are intended only for self-perceived mild to moderate hearing loss.
Real quick, Janice, before you move on, I saw Elliot raised her hand. Elliot, do you have a question so far?
Again, she sounded somewhat muffled, and maybe I'm losing my hearing. Maybe it's just me. Nobody else seems to be affected by this. This is probably how you find out you're losing your hearing. But her voice sounded muffled, and sometimes I couldn't hear it clearly.
Well, thank you for the feedback, Elliot. I could say, sitting here next to each of the presenters that come up, I can't see an observable pattern that would distinguish. I would say Janice is as loud as Kate is, and that's a compliment, just for the record. I'm not sure what else we can do at the moment.
Elliot, I think after this meeting, maybe we'll have our tech team troubleshoot some sound issues maybe on your end. But John, your hand is raised. Do you have a comment about sound?
The same problem that Elliot's having. It's not clear at all. When it's coming from the room, for some reason, it's muffled.
Do you mean, when you say coming from the room, just from the speaker that's presenting, or like is my voice muffled as well? Okay,
sometimes even when you're presenting, yours seems further away. The other speakers seem muffled.
Okay, we are going to try a little experiment here. We're using Dave's microphone. We're swapping things out, and we'll proceed, and we'll do check-in points so we can continue through this meeting. And then we will try to figure out how we're going to troubleshoot this for future meetings.
Great, thank you.
And I just want to clarify, you all are tracking that we are in the hearing presentations and you're seeing the slides. Are there any questions thus far?
I do have a question, but do you want to do that first?
I'm just trying to make sure we can catch up for those that are having hearing. And Harry and Monica, if you're having issues, please let us know as well.
And this is Harry. I can't find my raise my hand, so I apologize for that. But yeah, I've been having the same problem, and actually with Stella was kind of in and out, just as John described it. So kind of muffled, and I don't know if it's people are moving away from the microphone or what. But so yes.
Monica?
I'm not having any problems hearing.
All right, well, we will definitely add this to our list. I think we might need to look at speed, some receptivity issues since we're having some inconsistencies. But for the purposes, we do need to keep moving through this meeting. And I think because you have a visual representation of the materials and you're getting most of the information, I'm going to count on you to stop us for any clarifications. Go ahead and proceed, please.
Okay, Tom, did you have a question on the previous slide?
Yes. Yes. So how as a subscriber, how am I going to know whether, let's say I'm having trouble hearing, and so where do I fall in the spectrum? Who helps me make that determination? Do I go to a audiologist? Or do I think I can do it myself? And what's the process?
Well, my understanding of the point of OTC is just for perceived. So you wouldn't be required to see an audiologist. So if you are unsure where you fall in the spectrum, your insurance, through PEB, I'll get to that slide in a moment, but your insurance may cover a hearing exam by an audiologist, and then that would be able to tell you where you're at in the spectrum. But only the prescription hearing devices require an assessment by an audiologist. OTCs do not.
I'll just add from a primary care provider perspective, oftentimes if somebody says, my hearing's starting to get, seem off, they will say, here is an audiologist you need to contact so they can do a hearing test, so they really can figure out the gradation of hearing loss. So that's usually where things start pivoting. But a lot of people also, just like readers, they now with over-the-counter go and start experimenting and doing that self-care for their hearing aids.
Okay, next slide, please. All right, continuing with the comparison chart on this slide, the design of the OTC hearing instruments are intended as a one-size-fits-all, whereas prescription hearing instruments are customized to the member. And then on the last row, for verification of amplification levels, both OTC and prescription hearing instruments can be verified by a licensed audiologist, but again, it's not required for OTC. Next slide, please. So on this table, you're going to see a few of the top-ranked OTC hearing instruments in 2023, and this is according to the consumeradvocate.org research and reviews. Starting in that second column that's titled Battery with Standard, that differentiates between the two battery options, standard battery operated, or if it's a rechargeable battery. Moving to the right, you'll see whether or not the OTC hearing instruments is Bluetooth compatible. And then further along, if there's a warranty, what is the length of the warranty, how many model options the company offers, and then the price of the OTC pair on the far right-hand column. So you can see that the more expensive option at the top of the table really includes 2 battery options, Bluetooth compatibility, and a longer warranty.
This is Dave. First I want to check, was Janice coming in louder and clearer for folks?
Yes.
Okay, then we'll keep swapping my mic back and forth. I did want to be clear that the agency isn't trying to endorse any of these over-the-counter hearing aids. It's very purposeful that they're just listed as 1, 2, and 3 rather than individual company names. We're merely providing this information for showing some of the variability that's out in the market on OTCs. Again, it's not an endorsement of any specific product. It's really for purposes of highlighting the variability that already exists as a result of the federal change.
Okay, next slide, please. So this slide is to cover what is PEB doing right now for OTC hearing instruments. So as you see, for plan year 2023, most PEB medical plans do not or cannot cover OTC hearing instruments, and there are no intended changes on OTC coverage right now for plan year 2024. You'll see for Premera Plan F and G, that's the Medicare Supplement Plan F and G administered by Premera Blue Cross. It allows the use of any Medicare contracted physician or hospital nationwide, and that plan is designed to supplement members' Medicare coverage by reducing out-of-pocket expenses and providing additional benefits. It pays some Medicare deductibles and coinsurances, but primarily supplements only those services covered by Medicare, and hearing instruments are not covered by Medicare in that plan, so they cannot cover OTC hearing instruments. And you may notice that UMP is noted as OTC being covered under plan limitations. While the federal rule is intended to allow members to purchase hearing instruments without the need for a hearing exam, prescription, or a fitting adjustment by an audiologist, if a member were to meet those plan specifics, such as the purchase of a hearing instrument prescribed as a result of an exam, showing that the hearing is necessary for the treatment of hearing loss, it could be covered.
This is Dave. I'll just also draw an analogy. This is very similar to the medical FSA benefit, where you can't get reimbursed with pre-tax dollars for over-the-counter drugs unless you have a prescription. And that seems counterintuitive to people. But if you do happen to get a prescription while meeting the other plan coverage or criteria, then you can get reimbursement. And it's very similar to that.
And that brings me to the end of my presentation. Thank you for the opportunity to present. Any questions?
Just a small question. You mentioned plan year. Is that the same as a calendar year?
Yes.
Okay.
Other questions from board members? Not seeing any. Thank you so much, Janice, for this information. We will move on now to our next presentation, Smart Health Update. So Kristen Stoimanoff is our wellness manager in the PEBB division, and she's here to talk with us today with an update about the Smart Health program. Kristen's materials are behind tab 10, and I will just say that a few weeks ago I was able to join Kristen and her team and participate in a nearly 400-person event up in Linwood about worksite wellness, and it's great that they really are continuing to champion prevention, healthy work sites, healthy behaviors, and just help people recover as we come out of COVID. So Kristen is here. Her materials are behind tab 10.
Wonderful. Good morning, Chair Birch and members of the PEB board. My name is Kristen Stoimanoff, and I'm the Washington Wellness Program Manager, and I'm here to give you a Smart Health update. This is what I'm going to cover today. I'll start by talking to you about the transition of Smart Health to Secure Access Washington in October. I'll cover PEB Smart Health participation in 2022, including Limeade recommendations based on the Wellbeing Assessment Report. I'll talk about PEB program participation trends over the last 3 years, 2020 through 2022, and then I'll end by talking about our comprehensive Washington Wellness Program evaluation. Next slide. Okay, so let me start with the Smart Health transition to SAW, or Secure Access Washington. As background, SAW is the state's secure single sign-on portal for external users, and it's currently used for several Washington government services like driver's license renewal and filing for unemployment. It lets individuals use a single self-generated user ID and password to access all of these services, and all state external-facing applications have to use SAW as their identity provider for authentication. This is per the Washington Office of the Chief Information Officer. So in October, Smart Health came into compliance with the OCIO standards. And we knew it was going to be a big change, so we worked hard to prepare people for the shift. We did a couple of posts in Smart Health. So if someone had logged into Smart Health, they saw an announcement on September 12th, or anytime they logged in after that, letting people know that the change was coming and encouraging them to get ready by establishing a SAW account if they didn't have one already. And then a few days before the change, we put another post or announcement in Smart Health letting them know, again, the new login requirement is coming as of October 1st. We also sent emails to registered Smart Health users in case people weren't logging into Smart Health. We wanted to make sure they were getting the information. So on September 20th, same thing, a new change is coming, get ready by setting up a SAW account. And then on October 3rd, which was the Monday after the change went into effect, we sent another email letting people know the change is here. You have to set up a SAW account in order to log into Smart Health now. We had lots of support materials available. We created a really comprehensive Accessing Smart Health guide and then a one-page quick start guide to help people go through the instructions. We provided contact information for Limeade, for Washington Wellness, and for SAW, depending on the kind of problems people might be having. And we gave lots of direct assistance at benefits fairs, via phone, via email. Even at benefits fairs, literally helped people sign on if they had their phone or laptop with them. And there was a fair amount of pushback. A lot of people weren't crazy about this transition to SAW, but it is being required for more and more state applications. And as we transition from PEB My Account to Benefits 24/7, it's going to be required for all PEB members to log into Benefits 24/7 and make their open enrollment selections. So hopefully this will get easier for people as they get more used to using SAW. Next slide. Okay, so this is a snapshot of what PEB employees did in Smart Health in 2022. A little over 40% of eligible PEB employees were actually registered for Smart Health in 2022, and a little over a third participated in activities, and another third or so completed the well-being assessment. Overall satisfaction with the platform was at 4.2 on a 5-point scale. And when we look at the activities that were most popular for them, those are in the left-hand column under the blue bar, and complete your well-being assessment was at the top. It always is. It's required to get the wellness incentive, and it's worth 800 points. So that was way up there. And how do I find my $125 activity is also way up there. This is an activity that is in Smart Health. It's customized by health plan, and it really walks people through the steps of what they need to do to verify that their wellness incentive was applied. In addition to those two activities, Go Exploring was a big one. It encouraged people to find adventure close to home. Steps tracking activities are always popular, and they were this year too. And then we were really proud about that last one, Give to Others to Improve Your Well-Being. We've done that for 3 years, and it encourages people to volunteer or donate or just help out a neighbor or a friend, and highlights the benefit of helping others to take care of your own well-being. In terms of areas where people reported the best, that they were doing best in Smart Health in the well-being assessment, in the physical realm, nutrition and exercise and fitness rose to the top. Positive relationships and self-leadership were really positive for enhancing people's mental and emotional well-being in 2022. And work meaning and job satisfaction ranked high. But there's always room for improvement, and when people reported on where they needed help, sleep was right up there. Energy level, probably because they weren't getting enough sleep, was also right up there. And then belief in the company and square deal were rated lower. And this is interesting because you see that work meaning and job satisfaction, that personal investment in your work was high, but less confidence that their employers kind of had their back. And that square deal one in particular I want to explain. It's really this feeling that you're compensated fairly, that you're well recognized for your efforts, and when employees feel like they're giving an awful lot and not getting so much back, the questions that get at that dimension, the scores get lower. So this was a 2022 snapshot. On the next slide, I'm going to talk to you about those 2020 to 2022 trends. Okay. So I showed you on the last slide that about 40% of eligible Smart Health users had actually registered. And this first column, registration, is that number. So for 2022, that 70,727, that represents about a little over 40% of the eligible population. We've had pretty consistent registration trends over the last few years. It's been between 40 and 42%. All the other columns refer back to that registered number. So you can see in the second column the percentage of people who completed the well-being assessment. This is required in order to qualify for the wellness incentive, as is participating in enough activities to get to 2,000 points. That's in the fourth column. So the well-being assessment numbers went down a little bit in 2022, and participation is the number we're really keeping our eyes on. That went way down from 80% in 2021 to 37% in 2022. We believe there are a couple of factors involved in that. One is potentially the friction caused by that transition to Secure Access Washington that I just told you about. Another is something that I told this board about last year. We transitioned to the upgraded Limeade platform, Limeade 1, and that happened in April of last year, and that required a whole new sign-on process. It required people to download a new app. Between those two things, we definitely saw less participation between 2021 and 2022, so we're doing a lot to try to get that up. Dave, I don't know if you want to share some reflections that I've heard from you that's hit some people at the exact same time.
Yeah, the insight that I have is, we have and I'm not immune to this, we're either eager beavers or procrastinators. And so a lot of us, myself included, weren't signing in diligently at different points in the year. And so when I went to sign in November, I knew that I ran into both of these. So I can personally attest that I know that some people may have found it very challenging if they had to experience both of them at the same time. But we're really committed to helping people as we launch and keep going forward in the year. But those of us who waited until after October 3rd got to experience them both at the same time. And I can attest personally that was a bit challenging.
Thank you. It would have been challenging for me too if I hadn't been seeing all along that I needed to do these things. Do you have a question, Tom?
Not a question, but a comment.
Yes.
I also, as Connie can probably attest, have struggled with your SAW login. And I looked on my phone. I think I have about 6 or 8 on my different accounts because I kept forgetting all of my logins and struggling with them. So actually, Shatrina, when she did that training session, now I understand the process.
Okay.
So that makes it, perhaps that'll make it easier going forward.
Good. Yeah, I think this is something that is really challenging for a lot of people, and as we're required to use it for more and more things in Washington, hopefully we can all support each other and help each other. And if you have problems getting onto Smart Health and you think we can help, please always reach out. We've got our contact information at the end.
And Tom, I appreciate the feedback that during one of our, I think it was our pilot sessions that you're referring to, that our IT team, Shatrina, who's had presentations here at the board before, that her guidance was particularly helpful. We'll make sure to take that feedback back, Jean, and Alyssa, to others as we prepare rollout materials for retirees, and know that you found that particularly helpful.
Yes.
Michaela?
So one question, one comment,
Louder, please.
Sorry, 2 questions. Or one question, one comment. The question is, I know a lot of what is happening now is like integration between different apps. So like, for example, I track my steps, it uploads to there. Does that show up in participation if that's the way that I'm earning points?
Yep, it does. If you're tracking and it's showing up in the Smart Health portal, it will impact the points you get. It will impact whether or not
so you don't have to physically log in to...
Right.
Okay.
Some people choose not to, or sometimes there are glitches and Limeade has to help. But if you're getting your steps tracked and you've chosen that integration, it'll show up in these numbers.
Okay. And then the second question, or maybe just a comment, is I know previously I used to get a lot of email reminders saying like, hey, don't forget, or this new tile came out, and I haven't been getting those recently. Is that just a me thing, or is that a change in the program overall?
You know, a lot of reminders are still going out. I'm getting them. A lot of people don't know, and I think this happens a lot at state agencies. Outlook switched to having a focused and an other inbox. And if you're getting, I used to get all of my Smart Health notifications in my other inbox. Anyone who's not getting those emails, I would definitely encourage to contact our program, and I've got my contact information at the end. We'll make sure they have your email address correct, because you should be getting those. Yeah. Thank you for that comment. That's important for us to keep track of. And you know, we want to increase participation. We want people to take care of their well-being. We also don't want to leave money on the table. This is 25% of registered Smart Health users who got their incentive. It's much more, it's about 10% when we look at all eligible. And that, we just don't want to leave that money on the table. So we want people to take care of themselves and earn this wellness incentive that they are eligible for.
I think Kurt had his hand up
Oh,
next.
please.
Yeah, actually, Michaela touched on my question,
Yeah.
so thank you.
Oh, good, okay.
And I had a question, Kristen, this might be a little unfair, but do we have any first quarter data for registrants? Do we have any initial feedback of how things are coming in?
We absolutely have it, and I do not have it in front of me, but I'm happy to follow up. I'm sorry.
Next time. Other questions from board members? Not seeing any, so why don't you continue on?
All right, let me continue. So I will share with you the recommendations that Limeade made based on that aggregated 2022 data I showed a couple of slides ago. Broadly, they gave us recommendations about how we can strengthen our offerings, help employees and drive smart health utilization to help people improve their well-being and qualify for that wellness incentive. And the first category is around creating value for wellness coordinators, because our wellness coordinators often really are the gateway for employees to know about smart health, to take advantage of smart health. The more we feel like we can get wellness coordinators truly engaged themselves in smart health, the more we think they're going to push that information out to their employees. So a new thing that's available to us in Limeade 1 is we can create channels that are unique to specific groups of people. And this is kind of a closed group. We created a wellness coordinator channel and they have to opt into it. And then we can post resources, information. We can share promising practices and they can share with each other. At last count, we had about 115 wellness coordinators signed up for that, and that number's growing. But again, we really think the more they engage in smart health, the more they're going to encourage employees to use it. Limeade also really recommended addressing burnout and using a holistic lens to do that. So they're giving us tools around providing organizational support, manager support, and individual level support, including a manager toolkit that's available in Smart Health for anyone. It can be interesting if you are in a manager role and really want to understand how you can support employee well-being, or if you aspire to be in a manager role. So that's available to everyone on Smart Health now. And then finally, they're, of course, working with us to help drive that smart health utilization. And one of the things we're really trying to do is make it a one-stop shop for lots of information. There's information there about your benefits, about upcoming events, about other state opportunities. And we're also partnering with our business resource group partners to really try to enhance, improve the diversity, equity, and inclusion that is really reflected in Smart Health and center the voices of people who might be overlooked. And Michaela has actually been helpful to us in that regard. So, next slide. I want to give a little spotlight to addressing burnout, because again, I think this is kind of related to those lower work well-being numbers that we saw a few slides ago. Employees saying that they didn't feel like the square deal indicator or belief in company indicator was as high as it could be. It's really important to know that employee engagement did seem to go up in 2022, but burnout also can go up hand in hand with that, because when people put more and more of their resources and themselves into work, they're taking it away from their time at home and family. And if they don't feel like they're given the chance to replenish, reinvigorate at work, burnout can ensue. So we're doing a training for employees, we're doing activities in Smart Health, and there's going to be a PEB newsletter article coming out that points people to those activities. And oh, by the way, it's going to remind people about how to qualify for their incentive way in advance, so we can hope to bump those numbers up. Next slide. Okay, this is the last thing I want to tell you about. The Washington Wellness Program did our first ever comprehensive program evaluation last year. Our program really works to strengthen and promote all of the wellness benefits. Smart Health that I've been telling you a lot about, as well as our diabetes prevention programs and tobacco cessation programs. And we also use Smart Health to promote lots of other benefits available to PEB and SEB employees. So we do a lot of work to strengthen and promote those benefits, and we also provide training and technical support to employer groups to help them build and grow and sustain their own wellness programs. And so we did this evaluation to really find out how we can best support employer groups, and we used the CDC's framework for evaluation, or the Centers for Disease Control's framework for evaluation, to guide us. Next slide. The purpose, of course, was to get input into how we can develop new services or improve existing services to help employers with their wellness efforts. We had a 1 to 10 Likert scale, a survey with 1 to 10 scale for all questions, plus open-ended questions asking how we can improve. And we asked about those benefits that I've talked about, and we also asked about our processes, our support, our trainings, and the tools that we offer to employers to help them build and grow and sustain their own wellness programs. Next slide. We sent the invitation to over 1,700 wellness contacts. We had 126 respondents. It was a low response rate overall. It varied by employer group and it varied by PEB or SEB. So PEB response rate was 15%. When we looked at just state agencies, for example, the response rate was 33%. But we did get valuable information from the most engaged wellness coordinators. And when we look at their role in the right-hand column, we can see that in the PEB program, the majority of people who responded to this program identified as wellness coordinators or benefit administrators. But we also had folks who identified as wellness committee members or well-being champions or some other things. And I do want to note that they could select all that apply. So this there might be a wellness coordinator and a wellness champion, for example, who marked the same box. Next slide. We had lots of strengths that we were happy about and want to build on, and certainly opportunities for improvement. We were told that our responsiveness to requests in the FUSE system, which was the former system that benefit administrators used to ask questions about benefits or incentive issues, very responsive to that. Lots of people said they hadn't reached out to Washington Wellness, but for those who did, they felt our responsiveness was really high. We got high marks for our communications, both the frequency and the content. And we also got high marks for the quarterly trainings that we offer to wellness coordinators. But in terms of opportunities, we see that there is really a chance to engage coordinators in really increasing their utilization of the resources and trainings that we push out around specifically the diabetes prevention program and the tobacco cessation program. People just aren't taking advantage of using those resources as much as we would like. And one really interesting insight that we've gained about this is employers are really afraid to stigmatize employees by sharing information about diabetes prevention and tobacco cessation. So we've gotten requests and we are actually working on trainings to help talk about destigmatizing wellness communications. At the conference that Chair Birch talked about a couple of weeks ago, we did a tobacco presentation and it was the most sparsely attended presentation I had seen. And there could be a lot of reasons for that, but it's just something that people are not embracing as much as we would like to, even though it is really still the leading cause of preventable death in Washington State. So we got recommendations to share trainings that employees could participate in directly, and we're going to be doing one in June on burnout. And we, as I said, the stigma-related things. So we took all of this wonderful input as a team. We came up with a lot of strategies, and we prioritized them based on difficulty and perceived potential impact. And we've started moving forward with lots of them. So this is going to be an ongoing process, but we're really pleased for the input that we got, and we're really pleased to be taking very concrete steps to address it. So I have shared a ton of information for you on a lot of topics. Are there any other questions for me?
Kristen, I have one. The mandatory DEI training, the 24 hours that's going to be required over a 5-year period, is there any discussion about how that journey of self-knowledge and self-awareness about DEI enhancements could be translated into tile components or translate into smart health? Because it certainly feels like from a spiritual or a soulful or a self-knowledge perspective that it aligns beautifully with self-growth. And
there are absolutely opportunities, and we have I think this is related, somewhat separate but related. We have an upcoming meeting with the full business resource group leadership team. So I think that's something we can explore with them, which I'm excited about. But we're also doing a training in May called Taking the Lead. And one of the topics in that training is going to be DEI in wellness. And our own Juan Alanis is going to be one of the co-presenters on that. And I think we could explore that there. I think there are absolutely lots of opportunities.
Thank you. I just think it's something to consider as people, are committing to that process. And I believe it's a 5-year time frame that all state employees will be required to take the 24 hours of training. Is that right, Michaela?
Correct. And it's been reduced from 24 hours to about 8.5 hours as well.
The one piece of information and tempered optimism I have is we have to be careful about making sure that when points are assigned in the wellness program, we do have to be very thoughtful about making sure that people are in similarly situated situations. There are some wellness rules that we have to be very careful about. So I think it's a great area to explore. I do just want to highlight that, as always, the devil's in the detail, Tom. I say that to you a lot. The devil's in the detail with wellness rules as well, because especially with a 5-year timeline and making sure that it's equally accessible to people, there's a lot of different things to balance, but I think it's definitely something that we should look into to see if there's a way to support it.
I'll just add, I've been writing notes. I think there's a lot of opportunities to partner also along with the employee engagement survey and around that idea of reading a recent article that came out from Limeade around kind of the science of care, and when there's perceived caring by the employer, how burnout goes down and desire to stay goes up. So I think there's a lot of opportunities to partner there, and that the training is not meant to be kind of the silver bullet. So I think there's a lot of opportunities to say, regardless of the training, how do we build in kind of that self-awareness and knowledge and understanding and how it intersects with mental wellness into like that partnership, so that as we're learning, we do that internal work along the way. So I think there's excited about the opportunities there.
Absolutely.
Any other comments from board members or questions for Kristen? And again, I witnessed this team in action with 400 attendees statewide. It was a partnership with AWC up at Linwood, and it really was heartwarming to see that employers really were stepping up to say, we have got to create more nurturing environments post-COVID and really work on this whole wellness prevention journey. So.
Well, we appreciated your support, and Director Birch made awards to all of our employers who have gotten the ZO8 Award for Excellence in Wellness Programs, and they were really, really pleased. So nice engagement all around.
Keep it going.
Thank you.
All right. We are going to move into our next agenda item. Shauna Lang is our procurement management and monitoring section manager in the ERB division. So she's going to take us into this procurement update. Yeah, and her materials are behind tab 11. And Shauna, I think there you are, you're online.
Can you hear me?
Yes, we can, but you might want to amplify a bit.
Okay.
Try that again.
Oh, is that better?
A little louder.
All right. Better?
Yes.
Okay. Good afternoon, Chair Birch and members of the board. My name is Shauna Lang, and I'm the section manager for portfolio management and monitoring. I'll be giving an update on procurement activity today. For our first procurement, we have now concluded procurement for tax advantage accounts. This includes flexible spending accounts, or FSAs, and dependent care assistant programs, or DCAP. This contract also includes negotiation of administration of the $250 FSA benefit provided to eligible represented PEB members. First implemented in 2020, this program is negotiated with the unions and part of the collective bargaining agreement, in which we serve between 12,000 and 18,000 members each year. This contract also provides assistance to the Medicaid program, as it serves a small number of members of the Compact of Free Association, or COFA population. The contractor is paid separately, and no PEB or SEB funds are used for this. For this procurement, final signature happened last week, and HCA retained Navia as the apparent successful vendor. There will be another 10-year contract for this contract, beginning on January 2024 and running through December 2033. This contract will provide the same services as before, but we've added a number of additional features to improve administration. There will be more detailed and customized reporting available through the new contract to better monitor activity. Working through reporting and ops manuals, we can better assess reports. After several years administering the negotiated CBA benefit, we have included more thorough scheduled reporting to better track utilization and member issues. We have addressed the possibility of moving the HSA or health savings accounts administration to our FSA vendor, because currently all PEB and SEB HSAs are administered by separate vendors whose contract is not with HCA, but through our carriers who offer the high deductible health plans. There is currently no timeline for this move, but the possibility is built into this next contract. Seeing as FSA and DCAP participants claim their funds using healthcare services documentation, this new contract also enhances the number of security features and requirements that protect against inappropriate disclosure. This also includes a one-day breach notification. This procurement also reduces our per participant monthly fee and will save the state over $200,000 per year. Our second procurement is for the Smart Health program, our wellness program that encourages members to focus on all aspects of their health and wellness, with the incentive to earn a reduction for their annual deductible. Our current wellness contract has been in place since 2014. Procurement and selection have been completed. And our apparent successful vendor is WebMD, which will be a change in vendor starting in 2024. Currently, HCA is in negotiations with WebMD, and signature is scheduled to occur this spring. The security design review is under process and began in February. Full implementation will begin after the security design review is approved. This contract will start in January 2024. The change in vendors will have very little impact on how members recognize or engage with this benefit. The Smart Health name and URL are owned by HCA, so members will be interacting with the portal much as they do under our current vendor. The new contract will provide new options for members while remaining user-friendly. Next slide. Our third procurement is the Accountable Care Programs, which is also known as the UMP Plus plans. Current contracts will expire as of 12/31/2025. The benefit design in the procurement will remain similar to the current benefit design. Main changes will be in the areas of financial, clinical, and quality models. We are currently writing the procurement, and it will be released this summer, followed by an ASB selection in the winter of 23-24, and contract negotiations will be held in 2024. Implementation in 2025, and go live as of 1/1/2026. Our ACP procurement will focus on enhancements to the clinical quality and financial metrics and opportunities to identify other interested bidders who are not currently participating in the program. Any questions?
What does ASB stand for?
Apparent successful bidder.
Michaela, the way I think of it is when we go through a procurement and we announce an apparent successful bidder, what they've really won is the opportunity to negotiate a contract with the state. And until we actually execute the contract, they stay an ASB. If we never reach agreement, then we can announce a new ASB, meaning the second place gets an opportunity to negotiate a contract. So that's how I think of it. And this actually presentation really highlights the good breadth of timeline. The first one is in completion and we're moving on to implementation. The second one is we're in contract negotiations, and the third one is the beginning journey of the drafting process. And it's important just to highlight that our procurements are measured in years, not months. If we have a brand new idea for something today, we're easily talking 2025 at the earliest. So it's just the length and timeline of implementation and the complexity of our programs. As I always say, pull out your credit card. That's the year we're really thinking about, that when your credit card expires. It's a good model for what you're negotiating.
I don't think I'm seeing any other hand signals. Staff are confirming. All right. Thank you, Shauna, for your work in this area. We're going to move on next to our next topic, the Medicare update from Ellen Wolfhagen. She is our Senior Account Manager in the IRB Division, and she's coming back with additional insights on various Medicare topics. Her materials are behind tab 12.
Good morning, Chair Birch and members of the board. My name is Ellen Wolfhagen. I'm here to talk to you about Medicare today. Next slide, please. I'm going to cover some Medicare general aspects, including IRMA, which is the income-related monthly adjustment amount, and I will be sure to spell it out later. We're going to talk about CAPS survey, that's the Consumer Assessment of Health Plans, Healthcare Providers and Systems. That's what CAPS stands for. I'm going to give you a brief recap on the listening sessions that we are conducting and some information about public forums. Next slide, please. This is just a review that is more in-depth than we've done in the past on the different aspects of Medicare, the different parts that are involved. Part A is inpatient services. It's usually premium free. Part B is outpatient, including primary care, specialty care, infusion that's done at the doctor's office, and durable medical equipment. It is important to note that members pay separately for Part B outside of what they pay to HCA for premiums. And it's also important as we work through this year and the pharmacy changes that are being proposed through the Inflation Reduction Act, that some pharmaceuticals are covered under Part B and not under Part D. Generally speaking, however, Part D is the pharmacy benefit. It is also paid separately through a premium that the member pays directly to the Social Security Administration, but in the Medicare Advantage prescription drug plans, the MAPD plans, that Part D premium is included in the premium, so there's no additional fee there. Instead of the next slide, we're going to skip over to slide 5, please. And then we'll come back to 4. So Part A, usually when people turn 65, they enroll in Part A. It's through the Social Security Administration. If you are like me and working aged, you can be enrolled in Part A and continue to work. Part B is also usually upon turning 65, but you can defer again for employer-sponsored insurance if that's available, and you enroll again through the Social Security Administration. Part D is within 60 days of creditable drug coverage ending. As a reminder, most of the PEB insurance active insurance plans provide creditable drug coverage, and that means the coverage is as good as Part D coverage, but it is not a Part D plan, and the requirement is to ensure that the government is not spending too much money on drugs or having people pay too much money for drugs when they could be eligible for a reduced rate. Now we can go back to slide 4, please. So CMS, the Center for Medicare and Medicaid Services, assesses a surcharge on premiums if the member's income is above a standard level. The surcharge is called the Income-Related Monthly Adjustment Amount, IRMA. CMS looks at the tax return from 2 years prior, so not 2 years worth of tax returns, just the 2 years prior. For 2023, the standard level was $97,000 for a single tax filer or $194,000 for joint filers. If you exceeded those amounts, then IRMA was applied and it's paid directly to CMS. HCA does not have income information on members, so we cannot send out targeted communications saying you might be eligible for an IRMA assessment. Slide 6, please. So for 2023, this is the amount of the IRMA adjustment. So you can see if you, on the second line, if your income was above the standard level, you would pay $12.20 per month above the plan premium. And again, For MAPDs in PEB, the Part D premium is already included in our premium, but you would have to pay the CMS the $12.20 per month extra. Next slide, please. So this is a reminder that UMP and Kaiser, the retiree plans under those carriers include creditable drug coverage. It is not Part D coverage, and therefore there is no IRMA assessment. The MAPD, because it includes Part D, has a IRMA possibility. If one is paying IRMA on Part B premiums, and again, everybody in Medicare, in PEB, has to pay Part B premiums separately from the PEB premiums, and they do that directly to the Social Security Administration. If they were to switch to UHC, which has Part D in it, they would also have to pay IRMA on the Part D portion. And HCA is increasing its communications about IRMA and potential impacts to avoid member confusion. Any questions on that before I move to CAPS? Not seeing any? We'll go to CAPS. So again, CAPS is the consumer assessment of healthcare providers and systems. The goal of doing these surveys is to create incentives to improve the quality of care, produce comparable data on patient perspectives, and increase transparency. The surveys are issued by the Agency for Healthcare Research and Quality, AHRQ, which is a division of the Federal Department of Health and Human Services. CAPS is just one method of gaining information. All the plans except Medigap, which is Primera Plan F or Plan G, provide PEB-specific clinical quality measurement as well as part of their contract, which is separate and apart from any measures that are included in CAPS. The CAPS surveys are very broad. It's a standard survey process on a wide range of plans across the country, and it includes employer plans from both public and private employers. And Medigap plans do not do CAPS surveys at all. Next slide, please. Each plan reports the results differently. There's aggregated information on the book of business by plan for the Medicare Advantage population. By contract, we have asked United Healthcare to do a CAPS-like survey, so it will not be a CAPS survey, but it is something that is tailored specifically to us, and it will be for the PEB-specific population, and we'll have PEB-specific questions. And that's because we've reached the enrollment threshold that they set of 10,000 members. The United Healthcare survey will occur in March 2024, measuring the experiences in the plan year 2023. And results will be available in November of 2024.
Ellen, I have a question. So we just reached that member threshold, so we don't have prior period information, correct?
Correct. We don't have PEB-specific prior information other than the measurement aspects that we have in the contract, clinical measurement.
Do we have any other industry benchmarking data from prior year periods?
So the United Healthcare plan does have a CAPS survey that is nationwide. So our plan is modeled on that nationwide plan, and the CAPS survey does apply to that, and we do have prior year information. Does that answer your question?
Yes, that's exactly what I was looking for.
Great, thank you. Michaela?
Elliot.
Oh, Elliot, I'm sorry.
Is any survey done by an independent third party and not the plan itself with respect to UHC?
So all of the CAHPS surveys are done by an independent third party. It's the U.S. Department of Health and Human Services, the AHRQ. So does that answer your question?
I guess what and as Alan, as you've reminded me often, I'm confused, as you've said before. But aren't you contracting with UHC to do a survey on itself?
So yes, for the PEB, the CAHPS-like survey, that is part of our specific contract with PEB, but with United Healthcare. But we will get input from stakeholders on the kinds of questions that we should be asking.
Okay, that's the answer to my question. Thank you.
You're welcome. Next slide, please. For UMP, currently 2021 is the year that's available. 2022 results will not be available until August of 2023. Generally speaking, CAHPS surveys are done in the first quarter. Results are available in the third quarter, and they always reflect the prior year experience. All UMP plans are surveyed except for UMP Classic Medicare, and that's because the Medicare aspect of that plan is secondary to Medicare. Medicare is the first payer, so it really doesn't make sense to measure UMP there. UMP surveys about 1,100 members, age 18 and older. They're randomly selected, and as I said before, surveys go out late in Q1. They're done by Regents and SPH Analytics, which is Regents' vendor for the surveys. 89% of the respondents for UMP Classic rated the plan 8 or higher on a 1 to 10 scale.
What percentage of the total member population is 1,100?
That is a great question. I have to get back to you on that. I don't know the answer.
I see our fiscal team in the back saying it's approximately 1%.
And thank you for the assist from the financial team. Okay. KP Northwest, that's what KPNW stands for, Kaiser Permanente Northwest. Their Medicare Advantage is called Senior Advantage. Their CAHPS survey results from 2021. So CAHPS is done on a 5-star rating. The plan rated 4.5 stars. There are various elements. I just picked out 2 of them, care coordination and getting care quickly. It is important to note that the elements are weighted differently. So although you see the plan overall got a 4.5 and they had 3s in these areas, how could that be? It's because of the different weighting of the different elements. This survey is done for the Medicare Advantage book of business for their CMS contract. They have, under that contract, 103,332 members total. PEB has about 2,300 members in that group, so about 2%. And we gather also some non-Medicare specific information as part of the performance guarantees in their contract. And their CAHPS survey is done by the National Committee for Quality Assurance, which is also known as the NCQA. Next slide. Kaiser Permanente Washington, KPWA, has its own Medicare Advantage plan, which is called Medicare Advantage. It's also on a 5-star rating system, plan also rated 4.5 stars. And again, their care coordination and getting care quickly was at 3. There are 99,000, I'm sorry, there are apologize. There are 99,124 members total in the Medicare Advantage overall contract. PEB has around 23,000, or about 20% of that. Next slide, please. United Healthcare also does a survey also done by the National Committee for Quality Assurance for 2021. It's also a 5-star rating system. Their plan rated 5 stars. Care coordination was at 4, and getting care quickly was at 4. This survey was done on their Medicare Advantage book of business. For that contract, they have 1.5 million members total. For 2021, we had approximately 3,000 members, and you can tell it's a very, very small percentage. I'm not sure I can even get that small. 0.03 finance team. We expect not only our enrollment to increase as people make plan choices based on different elements that are available, but as the population ages, we are seeing a bow wave of people turning 65 or older and leaving the workforce in greater numbers, and so we will see probably more enrollment there.
Ellen and Dave, can you remind me what, I know we're above 10,000, but what is our current
Currently in
UHC MA enrollment?
Currently, we're at 14,218 in PEB complete.
Thank you.
And we have probably fewer than 500, I believe, in PEB balance, which is a similar but different plan offering, and we'll be looking at that plan in the future.
So, Ellen, I just want to make certain I'm clear. So, of the current UHC MA enrollees, the 1.5 million total, we are 14,218 of those.
So 1.5 million was their 2021 total enrollment.
Okay, thank you for clarifying that. Okay.
Yeah,
So they have updated.
They have updated,
enrollment.
yes, correct.
But that is specific to Washington.
The 1.5 million, no. That's their national, that's the national level MAPD contract, which is based as a 5-star plan.
You're right, 2021 figures. I think it too has mushroomed though, so that would be an important number to bring back to this board for future reference.
Absolutely. Next slide, please. Moving on to the listening sessions that we're doing. As a result of the board resolution in June, we are engaged in active engagement with our retiree population, and part of that is doing listening sessions. We've done 8 through March 31st. We've done some more since then, but obviously the slides had to be prepared earlier. Through March 31st, in those 8, we had 63 participants, 50% of which were in UMP. And these are simply high-level themes that I pulled out. This is not all-inclusive. This is not meant to be a complete review of what happened. But what we're hearing is loud and clear, maintain UMP choice despite the cost. HCA needs to do a better job of distinguishing between secondary insurance and Medicare Advantage and other Medicare plans. We've heard a lot of confusion about how do the plans actually interact with Medicare, and so we are doing more to clarify that. And everyone had at least one thing good to say about their plan, but everyone also had at least one thing that could be improved in their plan, and often more than one thing. And after all the listening sessions are done, they're currently scheduled through May 31st, and we'll have a total of 26. When that's all done, we'll provide a detailed report with more specifics, but I will be providing monthly updates. We are also offering in-person sessions, so we have had 3 so far. 4 were scheduled. With the same format as the virtual session, we invite 12 participants. They're facilitated by Noel Villarreal, who's our contractor. It's the same focused questions that we ask on the virtual sessions, and both HCA and Stakeholders Medicare Coalition provide observers to see the process. We had a session in Tumwater on March 29th, and we've just returned from sessions on the east side, April 11th in Cheney and April 12th in Yakima.
Ellen, although we have space for 12 participants, can you share a little bit about the actual current participation levels we've had in the 3?
Yes. So next slide, please. In the Tumwater session, which is the only one that I'm reporting on right now, we had 4 attendees. 2 were in UMP and 2 in KP Washington Medicare Advantage. We met at the Labor and Industries building in Tumwater, and what we have found is, in person, as I'm sure you're experiencing at the board meeting, generates more interaction, and it was a very lively discussion. I will say, although I don't have a slide on it, that April 11th we had 11 participants, and April 12th we had 6 participants. So there is a lot of interest in the in-person sessions as well. Next slide. So public forums are a slightly different format, and we have 3 of those scheduled. The first one will be next week, April 26th, and then May 17th and May 24th. And May 17th we added in as a reschedule from March because we just didn't have enough notice for people on the public forum, and we wanted to be sure we got a good representation of people. So this format is slightly different. It's also going to be virtual. It's over Zoom, but there'll be up to 30 participants who will be given 3 minutes each to speak. And there's no set questions or topics, so they can provide any feedback that they would like. And that's the end of my presentation. Oh, I'm sorry. I also am engaged in webinars. We're doing a lot more outreach, and we are creating some new web pages so that people will be more informed about the listening sessions that are going on, the public forums, and we are reiterating very prominently that UMP is not going away. And next month, I will also provide a feedback on pharmacy appeals and the process under the different plans, which I know was something that was brought up in a previous board meeting and through public comment. And now I'm done.
Thank you so much, Ellen. I just want to, again, provide some accolades to both you and Dave for really investing this time in community engagement and hearing from a person-centered approach to the challenges and opportunities. So we've got great foundational work that's continuing to evolve in this area, but I really think it shows a dedication and sensitivity about the changing dynamics, many of which at the federal level are completely out of our control, although we try to control them or maneuver them in the direction we want. But thank you both, because I know this is an enormous undertaking, and I want to make sure we get you the necessary resources as we keep building on this work.
Thank you very much.
Other board comments or questions? Tom?
I'm just curious on slide 14, the 8 sessions held. Were there, did you have to sign up? Were there restrictions on how many people could talk at those?
So the registration was limited to 12 people at each session, but we never actually received enough registrations to cut it off. There was always more room.
Okay. Thank you.
And Tom, I think part of that has been just our COVID reentry and wanting to have physical distancing and safe environments and whatnot. So staff have been very thoughtful about trying to make sure, that we just have all the right elements in place.
Okay.
I'm going back to slides 6 and 7. I know you're saying that there's no way to kind of know who will be impacted by Irma, but wondering if there's a way to identify like in people who are currently retiring and their income thresholds and kind of partner between state HR, retirement systems to see if we can, if there's a way to identify those folks and help them understand that they might be eligible, that they'll need to pay Irma.
Michaela, we can certainly look into that. One of the challenges when we've tried to estimate incomes for various fiscal notes, even for bills, is there's so many different retirement income streams that one can have that are even outside of DRS's control. So we often end up, it's a very low watermark because it's known as only a piece of the puzzle. So we can, not saying that it's impossible, but we've run into that challenge. So I just want to recognize that DRS only has a snapshot of an individual's income streams for retirement. It's certainly a possible piece of the puzzle that might indicate some people are, but it is imperfect.
I'm not seeing any other hands. So Ellen, thank you. We'll look forward to getting our next update. All right. We're almost there. Thank you, everybody, for hanging in with us. We are going to cover now the UMP Classic Medicare Pharmacy Benefits Insights from Molly Christie. Molly is our fiscal analyst in the FSD, the division, and she's got some insights to share regarding UMP Classic Medicare and the pharmacy benefits in response to some of the questions and ideas that were raised over the past year. Molly, welcome. And your materials are behind tab 13.
Molly, as you get started, I want to give one piece of context because I've had a couple of questions about this presentation since we released it last Friday. I want to be clear that these aren't specific proposals. The framework, and I know you're going to describe this a little bit, Molly, I just wanted to tee up a little bit more. In the last year, since last June, retirees have generated ideas as to if X was changed, would it make an impact on premiums, or what type of impact would it make on premiums? So some of these are analyses that we've done in the past, and we've refreshed it, and we wanted to kind of bring back our homework and describe the types of impacts with some of these ideas that have come up. I just want to be clear that at this point, none of these are specific proposals. Some people reached out to me asking about with an assumption that these were specific proposals that were being teed up. Right now, they're just discussion information points for you on some of these ideas. So go ahead, Molly.
Great, thank you. I appreciate that point. And thank you, Chair Birch, for the introduction. For the record, I'm Molly Christie. I'm on our IRB Rates and Finance team, and I will be presenting this analysis that we performed concerning the pharmacy benefit for UMP Classic Medicare. Just a heads up, it is a complicated topic. It is scenarios, and it is pharmacy scenarios. So historically, when we've had pharmacy scenarios, they do get a little in-depth. So please stop me if you have questions. Someone flag me down, and I can answer those as I go to make sure everyone is following along.
Molly, I was just chuckling, saying, what possibly could go wrong, and costs. Thank you for your good humor, everybody. Let's move into this.
So next slide, as Dave mentioned, the motivation for this analysis was stakeholder feedback that we received following the significant 2023 rate increase for UMP Classic Medicare. So during last year's board season, when we presented the rates, there was a lot of discussion during the season, but also outside of the board that we received about ideas, recommendations, suggestions for ways that we could potentially either control retiree premiums, like control that year-over-year increase, or even reduce that increase. And a lot of those key themes centered around pharmacy, because everyone has been listening when we keep saying pharmacy is such a big piece of our UMP Classic Medicare rate. Pharmacy contributes typically 60% or more of the total rate because we don't receive certain subsidies from the federal government for our creditable drug coverage. So we've come back year after year and said it's really, a lot of it is really the pharmacy costs, and there's unfortunately little that we can do to address that. But we wanted to perform this analysis and kind of, as Dave said, look at some previous analyses that we've done and bring it back to the board in this forum so that everyone can kind of understand if we did make some changes to the plan, what would that potentially look like for members. Next slide. So we did a formal analysis. We enlisted Milliman to help us answer the question, what would spending have been on pharmacy in UMP Classic Medicare if we had had different benefit designs? So we ran projections. We looked at different benefit design scenarios to calculate at a member level each member's cost sharing and their plan paid amount for 2019 through 2021. And we compared these amounts with what we actually spent for this period to see if there might be any savings. And so today's presentation, I'm going to walk you through some of these scenarios and the results of these scenarios. Yes, Elliot.
Two questions. First, I think, or suggestions, I think it would be good to tell people, not everyone may know what Milliman is. They might think it's an ice cream producer. And second thing, it might be good to remind us what cost sharing is, because this is a lot of very heavy data. Thank you.
Absolutely. Thank you for those points. Those are very well taken. Milliman, they are our contracted actuaries, so they help us develop our own rates for a uniform medical plan. They also help us with some of the more challenging questions that we get around our financial information and some of our claims data, so they help us run modeling and projections. So they helped us with this analysis. And then when I mention cost share, I am talking about what a member, retiree, and or their dependents will pay for healthcare out of pocket. So this is not the premium, which is paid monthly. This is things like your deductible, if you have a co-insurance, when you see a doctor or when you fill your prescription at the pharmacy, those types of costs. So I'll get into a little bit more specifics about what a cost share can look like. You can have a co-insurance or you can have a copay, and that is an element of one of the scenarios that I'll be walking through. So this is the analysis that we performed looking at this historical period, and it was really helpful. It was really enlightening, but it does have there are a lot of limitations when we're looking at a past period. So we can't say with certainty that these results that I'm going to present to you would be replicated in the future. We can tell you with some degree of certainty what might have happened if we went back in time and changed things. If things had been different for this period that we're looking at, that's where these numbers are coming from. But unfortunately, they're not guarantees of what our rates, savings, claims costs, those things would look like in the future. And that's because there are a lot of elements that go into our rate build. We look at pharmacy trend, we look at enrollment. Yes? Someone have a question?
No, Molly. I think that was just a cough. Go ahead.
We look at enrollment, we look at pharmacy trends. For instance, we know in terms of enrollment that a significant number of retirees left UMP Classic Medicare effective for this 2023 plan year. We have not factored that into this analysis because that's outside of the historical period that we are looking at, 2019 to 2021. We don't have claims for this year yet, so we're not able to know how that's going to affect our claims costs. We also can't predict for changes to things like the UMP formulary, which does actually change with some regularity. Things like members' health status, their health behaviors, drug prices, the drug supply chain, prescribing patterns. There are a lot of big driving forces that actually do have significant impacts on pharmacy trend and on our underlying rate, which then translate into premiums. So those are a lot of caveats, but the caveat to the caveats is it does really make a difference. And so that's why I don't want anyone to say, okay, if you said X dollars, that's what we can expect in the future. This is an illustration. And I think it gives us an idea of directionality, but it doesn't give us an idea of necessarily how many dollars we can expect to save. On to the next slide. So for this analysis, we had Milliman model benefit designs that differed based on some key elements. These are the typical key elements to a benefit design. So the first was looking at member cost share, and specifically moving from a coinsurance, which is where a member pays a percentage of the allowed amount for a service or a drug, to a predictable copay, and that's a set dollar amount. Increasing the maximum out-of-pocket amount, which is currently set at $2,000 for a single subscriber. We call this the MOOP. It's the maximum out-of-pocket, and MOOP is just an easy way to refer to it. And then we have tier structure. So in particular, we looked at creating a separate coverage tier for high-cost specialty drugs. So tiers are where drugs fall, and depending on what tier your drug falls in, that dictates what your cost share is for that tier. So for the remainder of the presentation, the structure that I'll walk you through is I'll first describe the scenario that we're looking at and how that differs from our current benefit design. And then I'll describe how it might impact what a hypothetical retiree would pay at the pharmacy, and then the cost implications for the entire UMP population at an aggregate level. So scenario one is moving from a coinsurance with a cap to a copay. So on the left, you'll see our current UMP Classic Medicare pharmacy benefit design. We have 3 tiers. We have the value tier, where a member pays 5% of the allowed amount of a drug up to a cap of $10. Tier 1 is where a member would pay 10% of the allowed amount up to $25. And then Tier 2 is where a member would pay 30% of the allowed amount up to $75. Specialty drugs would fall either under Tier 1 or Tier 2. There is not a separate tier for specialty under our current benefit design, and our maximum out-of-pocket is $2,000. So under the modeled scenario 1, members would pay a copay instead of a coinsurance, and it's an up to a copay. So it can be a little bit confusing, but what it means is that for value tier, members would either pay the allowed amount of the drug if it falls under $5, or if it's at or above $5, they would pay that $5 copay. Same thing for tier 1, so the copay would be set at $10. If the allowed amount is below $10, the member would pay that full allowed amount. If it's above $10, the member would just pay the $10 copay. And then for tier 2, the copay is up to $75. The last row in this table shows cost versus current. And what this means is it's a little confusing. It's not retiree savings directly. It represents the estimated average difference in paid claims between the current benefit design and the modeled scenario, specifically for incurred claims between 2019 and 2021. So this is what the plan actually paid for pharmacy claims versus what we think the plan would have paid for those same claims, but under this scenario 1 copay benefit design. So you'll see for scenario 1A, it's negative 3.3%. And this means we modeled a 3.3% reduction in pharmacy claims spending for this alternative copay design. Just give a minute in case someone has questions.
Not questions, we were just wishing it was a bigger number.
Can you say that last sentence again about what you modeled and what the negative 3.3% represents?
Yeah, so the negative 3.3% is the reduction. It's a 3.3% modeled reduction in pharmacy claims spending under scenario 1A versus our current benefit. So if we went back in time and we said, these are the claims that were actually incurred for this period, and this is how much we spent, if the benefit design had been a copay, this is how much we think we would have spent, and the 3.3% is the difference.
Got it, thank you.
Mm-hmm. And so the difference between scenarios 1A, 1B, and 1C is the move. So we did model some sub-scenarios where we said, okay, we changed to a copay. What if we also increase the maximum out-of-pocket at $1,000 increments? And you'll see that the cost versus current, those projected claim savings, really don't change that much. We have a 0.1% extra savings if we increase the MOOP to $3,000, and then there's no change in those projected savings if we increase the MOOP again to $4,000. So as I go through the rest of these slides for scenario 1, I'm not going to include scenarios 1B and 1C because they just did not have a significant enough impact for me to kind of continue working through those.
And Molly, this is Dave just stepping in for a moment. So this is one of the most regularly suggested ideas for benefit design change is increase the MOOP and an expectation that that could dampen or drive down premiums, and that's simply not what the modeling shows. And then you have to also factor in that with the Inflation Reduction Act, the market is going to be moving to a $2,000 MOOP. Washington was way ahead of that curve years ago. And so there's also, in addition to it not driving down or putting downward pressure on premiums, the market's going to be aligning to what the UMP Classic Medicare design has had for a maximum out of pocket as well. So this is exactly why we're bringing this presentation and information to the board, is to show and model some of the examples of some of the regularly asked and suggested ideas and how that does or does not influence the pressure on premiums.
Excellent, thank you. So next slide, this is our example. So this slide provides an example of member out-of-pocket costs at the pharmacy, member cost share, for a hypothetical retiree who's named her Jennifer, under the current pharmacy benefit design compared to scenario 1, which is what I just showed you. So in this hypothetical example, Jennifer takes 4 different medications. One is on the value tier, and then she takes 2 generics on tier 1 and a specialty medication that's placed on tier 2. And under the current benefit design, that's on the column that says current monthly member cost share, that's based on our current benefit design. She would pay for medication 1 of the allowed amount, which is $4.32 for her value medication, 5%. So her co-insurance would be 22 cents. Under scenario 1, where we're talking about an up to a $5 copay, she would pay the full allowed amount, or $4.32, because that amount is below the $5 copay. If we look at medication 2, which is on tier 1, the total allowed amount is $24.22. For her current benefit, she would pay 10% co-insurance up to $25, so she would pay $2.42 as her cost share. Under the copay structure, she would pay $10 because the total allowed amount of $24.22 exceeds the copay of $10. She also has this medication number 3 is a specialty medication, but it's on tier 1, so it's a high cost generic specialty medication, and the allowed amount is $305. So under her current benefit, under the current UMP structure, she would pay 10% of the cost of the allowed cost of the drug up to $25. Now, because this drug is so costly, she's meeting that $25 cap, and so she's paying $25. Under a copay, the copay limit for tier 1 is still $10. So she would pay less. She would pay $10. Finally, her tier 2 medication, her 4th medication is specialty, and it's very costly. It has an allowed amount of $13,400. Under her current benefit, she would pay 30% up to $75. This drug far exceeds $75, so that is what she will pay as her cost share. And then under the copay structure, the copay is also up to $75, so she would still pay $75. So in summary, if we compare the current benefit to a copay, in 2 cases she would pay more, in 1 case she would pay less, And then for her specialty, she would pay the same amount.
I know that there are a couple of board questions, Molly. I think you should go through the next slide and then we'll take questions on all of this.
Okay, sounds good. So the next slide shows the annual member cost impacts on an aggregate or population-wide basis. So the last slide I showed you a hypothetical example for one individual. Now we're zooming out, we're looking at the whole population. And as I mentioned earlier, I'm only presenting on scenario 1A, which assumes a $2,000 maximum out of pocket. So you can see the impacts are divided into 3 buckets. We have members who pay less, members who pay more, and members who have no change in their annual out-of-pocket costs or their cost share when we're comparing the current benefit to this modeled scenario 1A benefit. So for the first bucket, you can see that 1.8% of members would pay less, and on average per year, they would pay about $30 less under a copay. But looking at the center bucket, you see that 95.1% of members would pay, on average, $122.52 more per year on their prescription drugs when they fill them at the pharmacy. And then about 3% of members would have no impact to their cost share. A lot of these members are probably those who, during this historical period, did not use their benefits, so there would not be a huge change to them. Some of them might also be members who only use specialty drugs, where we found that there was no change to their cost share. I will pause for questions.
We're going to go to questions. I just want to drive home a point, and correct me if I say this wrong, Molly, but pulling up to the 50,000 foot level, the suggestion that we often hear is, I'd love more predictable expenses on my drugs by having a co-payment model than a co-insurance model. Although it would be more predictable, what our modeling shows is it would ultimately be more expensive to the member. And can you give any insights on the relation to premiums, the directionality or any pressure on premiums?
Yeah, so the general, the way this typically works, because all plans can do this a little bit differently, is that if you increase a member's cost share, whether it's through a copay or whether it's through some of the other changes that I'll talk about today, if you're increasing what a member pays out of pocket, you're going to typically see a decrease in premiums because it's shifting costs. It's the actual total costs to cover a population are not changing. The benefits costs are what they are, but when they're paid changes. So you can either pay them on a monthly basis as part of your premium, and that's spread across the population, or you can pay them on an individual basis at the pharmacy when you fill your prescription, or at the doctor when you go to the doctor. So what we do see, and I'll talk about this a little bit later once I walk through all of the scenarios, is that we do see a potential decrease in premium. And again, we're looking at a historical period. This is not projected savings for the future, but if we looked at this period and we said if the benefit had been a copay, such as what I'm presenting here, we do think that there would be a decrease in the monthly premium. And it would actually be exactly about $122. So you'd be paying $122 more on an annual basis for your prescription drugs, and you'd be saving about $11 per month or $122 on your premium. So it's truly just an example of shifting how those costs are paid.
Thanks, Molly. Now I know Harry had his hand first, and then Elliot.
Okay.
Yeah, can I go back to the first slide? I need to get myself deconfused. The one, that wasn't the first slide, I'm sorry. It was the one that showed the cost versus the current. That one, thank you. Molly, you said we, and I need to make sure I understand who or what we is on that minus 3.3. Is we the plan? Is we the group of subscribers who were paying? So if you could help me with that, I'd appreciate it.
Yeah, thank you. When I say we, I mean we UMP, we the plan. So what the plan is spending on claims would decrease by the amount shown here. that has to go through a rate development process where we layer on pharmacy trend and enrollment and these other things, these other projections, where then we get to a premium. But this is kind of one of the pieces, the base pieces of that premium. We look at what we spent on claims, and when I say we, the plan, uniform medical plan.
Okay, I understand that. So what suggests to me then, while the plan would save some, actually it would be shifted to the participants, that 95% would actually increase.
Correct.
Thank you.
Dave, this is Sue. I also want to note that value tiering, this to me also shows the efficacy of what we put in place in our value-based pharmacy modernization that has been in place 2 years now? 3? God, where is time going? Anyways, so I do just want to point that out, because to me, Harry, the 5%, 10%, 30% in the tiering, you know, we're just again shifting that to the subscriber, and that is why the plan reaps a little bit of savings, but it doesn't translate. It is exactly as you suggested. We're just shifting costs to the subscriber, not in this modeling.
Yeah, and because this is a self-insured plan, the plan is not retaining those savings. Those savings would be passed through to premiums. So there would be a reduction in premiums, but that's where the cost shifting happens. The reduction in premiums is equal to the increase in out-of-pocket costs, because it's like matter cannot be destroyed, right? It has to go somewhere.
Right.
So the benefits costs are still the same. It's just how are they being paid for? Do we reduce premiums for all members, whereas most members, 95%, are just going to pay the same amount when they receive their prescriptions?
I want to make sure we go to Elliot.
Yeah, my quick question is this. I'm looking at page 6. Maybe I've run into this and don't know what it is. Could you explain the value tier? What is a value tier?
So I will give it a shot, and we do have our clinical pharmacist Luke is on the call as well. So Luke, if I screw this up, please chime in, or Chair Birch, I'm sure you could help with this as well. But the value tier, these are medications where we want to incentivize their use because they've shown that they're I'll say that they're cost effective, but they're also just effective in terms of improving member health. And they typically are also low cost. So I will not name what drugs are on the value tier because I might get those wrong. But I think they're things that typically treat some of the more common conditions that we see, such as like high blood pressure or that type of thing. But again,
so this might be generics. Might be.
I think they're commonly generics, and I'll leave it at that. I will welcome any other clinical
Elliot
on the value tier.
Elliot.
Yeah. Hey, Elliot, this is Luke, pharmacist
Yeah.
at HCA, and that's a great question. So value tier, like Molly described, are commonly low-cost, high-value medications. So we're looking at a lot of generic medications for blood pressure are on the value tier. Some of the low-cost generic antidepressants are on the value tier. Our preferred insulins are actually also on the value tier as well. And so those are kind of the genre of medications on the value tier.
Thank you very much. I had no idea.
Since we're still on slide 6, I was also thinking about another common question I hear, or something like, if this type of change went in place, we would hear from a subset of members who say, I used to pay 22 cents, I'm looking at the value tier specifically, and now I'm paying $4.32, and that's I can't do the math that fast because I'm not in finance, but it's multiple 100% increase. My drugs went up so much. And the challenge that we often have is if you netted out all of these changes for Jennifer in this hypothetical scenario, she actually has a slight net reduction in her monthly prescription costs. But when you look in each in isolation, you see those larger changes and you go, why did this medication go up so much more? And so it's really incumbent upon us, and one of the challenges we have is helping people pull back and look at the overall picture, all of their drug spend, all of their out-of-pocket expense, and compare and contrast that with what they're paying on a monthly premium basis. So it does get really complex, but I didn't want to lose the opportunity to highlight for Jennifer in this experience, when she's getting that first medication number one, yeah, it's absolutely true that her medication went up $4.10, and that's a multi-$100 percent increase. But we really have to help people pull back and look at the overall net effect of what happens when a plan change goes into effect. But I'm positive we've all encountered scenarios where in isolation we see that large increase and have to then in our own lives pull up to the big picture.
Molly, why don't you take us into scenario 2?
Perfect. I think that's slide 8. And this is going to follow the same structure, so hopefully it makes a little more sense now. I'm going to describe what scenario 2 is and then give that example, and then talk about the aggregate number impacts. So scenario 2 retains the same cost share for the value tier 1 and tier 2, but then we create a separate specialty tier for high cost specialty drugs. So under scenario 2A and 2B, you see that specialty tier either has a 30% coinsurance up to a $100 cap, or a 30% coinsurance up to a $300 cap. The maximum out of pocket is not changed. It is still $2,000 per subscriber. And the cost versus current, these projected savings for the historical period are relatively minimal. So under scenario 2A, where the out-of-pocket is capped at $100 per prescription, the potential claims savings were about 0.1%. And for scenario 2B, where the member cost share is capped at $300, the estimated or modeled savings were about 0.5%. So we're not seeing a significant reduction in modeled claims costs for creating this specialty tier. And the idea behind this was, we have presented before, and it is true that specialty drugs are a significant portion of pharmacy spend because they are just so costly. They tend to be, their prices tend to be pretty volatile. And so the idea was, well, if we have a small number of members who are on those, maybe we have those members pay more for those prescriptions. And that would help lower the cost for the rest of the group. And we're just not seeing that. And as we'll see on the next slide, I think this is primarily because specialty drugs are just so costly, and I'm going to give the same example of Jennifer, who has a specialty drug with an allowed cost of $13,000. The plan, even if Jennifer is paying $300, the plan is still picking up over $13,000 for the cost of that drug. So it's still a significant portion of overall spend. So on example 2, or scenario 2, in our example of Jennifer, she would pay the same amount for her value tier 1 and then her higher cost tier 1 specialty drug, but then her tier 2 specialty would move to a separate new specialty tier. So it says tier 2 here, but under this hypothetical scenario, it would be, we could call it specialty tier, we could call it tier 3, whatever it would be. So instead of paying $75 or 30% up to $75, she would pay 30% up to $100 or 30% up to $300. So for this drug, she would be paying either $25 or $125 more, presumably per month. It kind of depends. I don't know with this drug how often she's filling it, but this would be per prescription. And we still have that $2,000 maximum out of pocket, so she would probably reach that pretty quickly if she were filling this drug every 30 days. So going to the next slide. looking at the annual cost impacts on an aggregate level, then we see that compared to the current benefit design, most members would not be affected by this. And that's because almost 98% of members are not using a specialty drug. So you can see in the no change bucket, 97.8% of members would not experience any difference in their annual cost share. But about 2.2% of members who use specialty drugs that we would move into this new tier would pay more. Under scenario 2A, which caps the member cost share at $100, on average, these members for this historical period would have spent about $207 more per year on their prescription drugs. And under scenario 2B, which has the $300 cap, they would have spent about $860 more annually. I will move on to the third scenario. This is kind of a hybrid. So it's the copay structure that I presented in scenario 1, plus the separate specialty tier that I just presented in scenario 2. And this shifts the value tier, tier 1 and tier 2, from a member co-insurance up to a cap to a copay and up to copay. And it's the same copay amounts that I presented in scenario 1. And then creates that separate specialty tier of 30% up to $100 for scenario 3A, or 30% up to 300, or up to 100, or 30% up to 300 for scenario 3B. The potential claim savings here, because we're smushing those other two scenarios together and creating a hybrid, are slightly higher than scenario 1. So the estimated average difference in paid claims between the current benefit and the modeled scenarios is 3.4% for scenario 3A and 3.7% for scenario 3B. Scenario 3, so under our hypothetical member scenario, our member Jennifer would pay more for her value, low-cost tier 1 generic, and for specialty medications. She would pay less for her high-cost tier 1 generic because of that $10 copay cap, which is less than the $25 cap under the co-insurance. And then again, her tier 2 specialty medication would move to its own tier with a higher cost share, so she would pay either $100 or $300 for that specialty drug. And then at the population level, we find that under scenario 3, most members would pay more per year on prescription drugs. In scenario 1, it was 95.1%. Under this scenario, it's 95.2%. So the middle bucket shows that the majority of members will pay between $125 and $140 more on average, or they would have for this historical period. And that's because we've layered on this specialty drug tier in addition to the copay. Great. So this is my summary slide. This is the last slide. As Dave mentioned, we don't have a proposal for you. This was kind of an illustration. We wanted to present this because these are questions that we've had before, and we wanted to be responsive to the member feedback and the stakeholder feedback that we received. So we did find that there are potential cost savings for UMP Classic Medicare under different pharmacy benefit designs. But as you'll have noticed, everything we've shown you today shifts some costs out of pocket to members when they fill drugs at the pharmacy. So that is how these scenarios generate savings at the plan level. And we know that there's a lot of interest. What everyone really wants to know is, okay, well, but what does this mean for our premiums? And I already mentioned this, it can be really challenging to estimate what our premiums could have been under a different benefit design, because there's so many factors involved. But based on the analysis, with all that being said, we think that there could have been potentially $11 for scenario 1, $11 per month in premium savings. But for scenario one, we also showed you that 95% of members would have paid $122 more annually out of pocket for their drugs. So it is truly just a situation where costs are being shifted, and it's impacting most members. So there are a small portion of members that would either not have a change or pay a little bit less, but for the vast majority of members, they're really just paying differently. Do you want to pay a little bit more in your premium and pay a little bit less monthly, or do you pay a little bit more monthly but pay a little bit, or pay a little bit more annually in your out-of-pocket costs and pay a little bit less monthly in your premium? I don't know, Dave. That's what I have. I don't know if you have any other thoughts, if there are additional questions about what I've presented. I welcome questions now or questions after the fact if you think of things and you want to email me. I'm always available.
Yeah, thanks, Molly. Again, this is not going over every scenario of all the suggestions that have come up in last year, but some of the most common ones. And what you're really, my team knows I like to speak by analogy. This is kind of rearranging the deck chairs. It's squeezing the balloon. You don't change the volume of the balloon. It just pushes out pressure a little bit here, a little bit there. But Molly is describing in these three scenarios the changing from a co-insurance to a co-payment for more predictable idea, the increasing the maximum out of pocket because some people may be willing to pay more in a single year, or creating a higher cap on specialty drugs so that those who are higher utilizers of specialty drugs pay more over the course of the year. Those aren't making substantial changes. Molly described that some of those scenarios landed around $11. A reminder to the board that last year the premiums went up $74 per month. And so even these types of systemic changes that are regular proposals or ideas in the context of the overall spend of the plan, because drugs are just expensive, and without those federal subsidies, there's just this structural disadvantage that the finance team has been describing for the last couple of years. These ideas are, Sue, I love your analogy of there's very rarely silver bullets. They're usually shrapnel. This is barely even shrapnel in the context of what's going on within the structure of this plan. And so again, we wanted to just provide this context on these regular questions. Sue?
Molly and Dave, I want to thank you and the whole finance team back there that are still raising their hands doing those percentages. Did you see how fast they were throwing those numbers out? It was so impressive. I think Dave hit it on the head. I mean, we have to go through these exercises to understand, but really where we should be putting our energy is how do we get healthcare costs under control writ large, instead of just shifting around the responsibility of who's paying. So I love being in an organization that has efforts going on in that arena, and staff are always looking at that, how they bring us the best opportunities. And I go back to the value-based formulary, which I know we struggled with initially, but boy, I look at how that already squeezed so much unnecessary cost and advantage to people. So I know I see our fiscal leader back there, Megan Atkinson, who's going to keep coming back to us with ideas as Milliman and these experts have any other scenarios. But again, I think as much as this board can keep playing a part in the other processes around healthcare costs in the system through some of our other efforts, the Healthcare Cost Transparency Board, our Health Technology Committee, where we are driving efficiencies and driving towards value. The work that Cade brought up earlier around PARs and getting administrative simplifications and efficiencies, these things are where we're going to probably get more return for our members, but we simply have to keep doing both. So thank you, Molly. That was a long exercise, but I think it's really important to take the public through what we are constantly doing to try to deliver greater value for what we're paying. And I remind you, this is not unique to Washington. On this planet, the U.S. is not getting great value for what we are needing to get much greater value for. We really are, unfortunately, ranked very low in getting value out of our healthcare system. So we will keep after all the efforts while we bring you more current information. And I want to move us on. Thank you, Molly, and the whole fiscal team back there. Everybody, the next meeting is Oh, I'm sorry, I'm so sorry, I turned the page. It is time for public comment. Is there anyone on Zoom that would like to provide comments? I see staff beginning to kind of take some notes. What I'd like to do is work with staff to gather that list of speakers to effectively manage the time allowed for public comment. I'd ask speakers to please keep their comments to around 3 minutes or less. And if you are virtual, you're going to please click, raise your virtual hand. I know many of you are right now. And we're getting you in the queue. And if there's anyone in the room, I don't see any hands going up. Looks like all staff. And Dave, do we have that list of speakers? Hang on just a second. So we're going to begin with Amy Fortier. She is our first in the queue. So Amy, if you will go ahead and unmute yourself, identify yourself, who you're with, and share with the board your comment. Welcome.
Hi, my name is Amy Fortier. I live in Sequim, Washington. I'm a retiree, but also a member of the Retired Public Employees Council. I'm asking this question on all retirees' behalf, though. I want to thank Stella for her presentation about contracting and Dave's supporting comments. Would be very interested if the board materials could begin giving us a progress report on the contracting schedule and which plans and their both their renewal dates and the procurement schedule for them. I think that today's presentations have reinforced the need to look at some value-based areas, and would be very interested in seeing how that gets injected into the contracting process. I also want to say thank you for all of the presentations today. Some of them were very complex, and appreciate getting the information in a way that's understandable. Thank you.
Thank you for that, Amy. There is also more information that is published at the CMS site too about where they are driving towards transparency data on value-based contracting. So as those things become more available and useful, we will bring those to the board and digest that information as well. But Dave, I see him saying he will add that to his list. All right, our next public comment is from Nathan Johnson. Nathan, thank you. I think we met last week. It's good to see you both again. If you'll identify yourself and your other responder, I think the two of you, you're conserving time, but anyways, if you'll identify yourself, who you're with, and share your comments with the board. Welcome.
Thank you. My name is Nathan Johnson. I'm owner of Tick Clock Drug Pharmacy in Colfax, Washington. And I believe, and this is Katie Johnson, she's a pharmacy manager that works at the store as well. And I think we gave you guys the presentation about the Kaiser mail order, first bill requirement, mandatory mail order. And we just wanted to comment that we think it's ultimately hurting Kaiser members not being able to get their medications where they want to go. When it was voted on that mail order was going to be mandatory for them, they weren't made aware during the open enrollment session. So most of them in January came to us asking us what this was all about, because we were an in-network pharmacy, but obviously not a Kaiser pharmacy, so they thought they could still come to us for their medications routinely like they have been for 30, 40 years, some of them. And so we're just asking you guys to take a look at that presentation and reconsider doing the mandatory mail order next year for the Kaiser members that choose that plan. And for that, I'll let Katie.
Yeah, I would just say,
We've tried talking with Kaiser. I've had lots of members calling into Kaiser and telling them we don't want to go to a different pharmacy. We're in a rural area, so the nearest Kaiser is over 2 hours round trip. So if patients want in pharmacy, in-person care, they're going to have to, pretty much make a day of it to go to Spokane. Otherwise, they're going to be forced to use the mail order service. And I've had several patients who have tried to opt out of it, but Kaiser isn't making exceptions. And patients have just been really frustrated they feel like they weren't aware or notified properly. And they want us to be here to continue filling their medications. And, when insurance companies put restrictions like that, all the smaller rural pharmacies are, going to have a hard time being here when they need, the critical medications quickly. And then also it poses a risk as far as drug interactions because we don't have information as far as what they're taking currently, and then we're filling just their acute antibiotics and things. It just doesn't seem like a very good care plan. It's, not what the members thought they were signing up for, and it's just not good for our small business. So we've tried to convey that to Kaiser. We've talked to the Insurance Commission. We've talked to local legislators. But what we're kind of being told is it's ultimately the PEB and SEB board allowing Kaiser to do that. And so we are just coming here to, voice our opinion on it and hope that you'll reconsider allowing Kaiser to put that restriction in 2024. And in the packet that we gave you, the slides, there's also links to media coverage and some of the local legislators and just how it's affecting our area.
Thank you both for your comments. I know Dave has some information. Dave, do you want to?
Yeah, I did want you, Nathan and Katie, to know that the PEB board did receive your materials as part of their packets in advance, and we have followed up with the SEB board from last week. Last week, I'd let you know that they hadn't seen them before the meeting, but this board did get the materials before this meeting, so they did receive those in anticipation of your public comment. And I want to share with the board information that I similarly shared with the SEB board last week on this topic, that we are anticipating during the upcoming renewal process that has already begun for the 2024 board season, for the 2024 plan year, that Kaiser will present information with options related to changing this first fill process that we'll be bringing to you starting in executive session as we talk about some of the incremental cost that would be related to making a change. But that certainly is, we're anticipating that there will be an option for the board to visit this decision again for the 2024 plan year, both boards.
Thank you both very much for your comments. All right, next in the queue is Aruna Bhutta. Aruna, if you'll unmute yourself and identify who you are with, who you're with, and state your comments before the board. Welcome.
Thank you. My name is Aruna Bhutta. I'm from Spokane, and I'm a retired social worker and ARPEC member. My question was following up on Nathan's comments about the rural pharmacy. Is there any possibility that could be a special enrollment since all these changes were made after the people had already chosen the plan in November and these changes came about in January? Is there any possibility for that so that the people's needs are met and health and safety is also needs are addressed? Thank you.
Dave, I think I believe that we will likely have resolution of the issue, that we wouldn't need to do some sort of special enrollment period. But Dave, do you want to comment further?
Well, I think it's going to be helpful to bring back to the board the communication strategy that Kaiser used as this was rolled out. Typically, when a benefit change is made, it's made effective January 1st, and there is communication that flows during the open enrollment period. I've seen some of that communication plan that was utilized, and I think it would be helpful to share both with the public and the board kind of what that communication strategy was that Kaiser did use during open enrollment. but an open enrollment under these circumstances, keeping in mind that special open enrollments are dictated by IRS code, because for the most part people are using pre-tax payroll deductions for their plans, and so the IRS has limitations on what can be done retroactively. If people change plans prospectively, they may reboot their deductibles. Our healthcare system in our country is very complicated, especially when you layer on tax codes. So it's certainly something that we always keep in mind, but I think an important part of this is to bring back to the board what that communication strategy was, and then look for areas to improve that for benefit changes, because every year there are some sort of benefit changes that get communicated. I think that's an area that we can look at and would be helpful.
And Tom, I'm sorry, did you have a comment?
I actually have a question.
Regarding this issue? Go ahead, and then if Laurel Lemke would prepare to come off mic, Tom, we'll take your...
Or do you want me to wait until after?
Let's let our public commenters go first, since if you wouldn't mind. So Laurel Lemke, I think your hand is up. Laurel, go ahead and introduce yourself, who you're with, and...
Thank you. I'm Laurel Lemke, and I'm retiree, and I'm part of the RPEB in Chapter 12, and I did a public comment a couple meetings ago about a disparity that Kaiser Permanente was not offering home hemodialysis. And I wanted to say that one of the, I was called by a member of PEBB board and from the PEB Association, and it has been rectified, and we're just going to start doing that. And so I really appreciate that, and looking forward to having more opportunities to talk to, I think what would be helpful is, I know I do a renal support group that's nationwide, but looking for more opportunities within state to talk to other people who are looking for services. And I know that because there are several other people from Kaiser that want to do this service. But anyway, I just basically doing a shout out and a thank you.
We'll always take those, Laurel. We take all sorts of feedback, but thank you for that, and I'm glad you are getting the care that is needed. We appreciate your feedback. I have Ann Monroe in the queue, and then I'll circle back. I'm not sure, Nathan, if you just haven't put your hand down or if you wanted to have another comment. But Ann Monroe, let's go ahead and take you first. If you'll unmute yourself.
Yeah, my name's Ann Monroe. I'm the benefits director actually at Washington State University, just down the road from Colfax. So just a little feedback on what I've heard. Of course, we got a lot of feedback from our Kaiser folks on this mail order, and many of them were saying they were not informed due to the amount of email that we were receiving and contacts. I did a full investigation just for the greater good. I did find that Kaiser sent out a mailing to all of their participants in October, November of 2022, announcing this change. Of course, you guys listed it in the For Your Benefits newsletter. And then we, WSU, do a lot of open enrollment communications, and this was part of our communication as well. In talking to many of the people that I spoke with, just kind of investigating the topic, I would say the majority of them said we didn't read anything because we were happy with what we had, and we therefore didn't read these communications to be aware, because we were just going to stay with the same plan. To which is that learning moment of, even if you like your plan, you definitely need to be reading the communications you receive, because somebody may be communicating with you about changes to your plan. But I just wanted to provide you with some of that feedback. Same thing, lots and lots of concerns about this. People very frustrated saying they hadn't heard. And so that's why I did the investigation and sent out the follow-up communication to our Kaiser participants, letting them know communication had been sent out. It just may not have been something that they noticed.
Thank you for that comment, Ann. All right.
No, on to that. If you don't mind. So
I'm sorry, just one moment, please. Okay, go ahead, Nathan. So you were next in the queue, or? Katie.
I just was gonna note, so I think part of the confusion with the information that went out is because we are a network pharmacy, or there's lots of network pharmacies for Kaiser, because I had a patient who actually called in after they did read the letter in October that they received, and so she called and said, I always fill at 10 o'clock drug, is that gonna be a problem? And she was told, nope, they're in network, you're good. And so she took that as, okay, they're good, but they failed to mention the first fill program. And so it is true that she's good on acute meds, but not on her chronic meds. And so I don't know if they just need to revise what they're telling people too, because she was really upset because she said, I called and checked on this and they told me you guys are in network and there's no problem. And it just seems like sometimes the information people are getting from customer service isn't quite aligning with how it's actually working.
Okay, thank you again, Katie. We hear your comments, and the board will be, again, bringing this issue back. And I know staff are working on it concurrently. Staff members, is there anyone else in public comment queue? And again, I'm looking around the room. Nobody has come in or signed in for further public comment. Board members, Tom, you had a comment or a question? Go ahead.
Yeah, I have a question. So I want to make sure that I understand this issue that the Johnsons have presented. Let's say I live in Kettle Falls, Washington. I have a local pharmacy that I go to get my medications. If I'm a member of Uniform Medical, or if I'm a member of United Healthcare, I can continue to go to my local pharmacy to get those medications, but if I am a member of Kaiser, I no longer can after that first fill. Is that what I'm understanding?
So, Tom, each of the plans has different, so I'm trying to think how to formulate the information that I can share, or that I have in my mind. Each of the plans has different prescription fill processes. Some of the plans incentivize mail order, but Kaiser, in the current iteration in 2023, in Kaiser Washington's network, has this program that after the first fill, and it's really second fill because you have a one-time grace for a second fill, but it's called the first fill program. After that first fill, which you can get in your local pharmacy, and then you get a grace of a second fill as you're learning the process. After that is a mandatory mail order process. That mandatory mail order process doesn't exist in any of the other plans. Some of the other plans, though, do incentivize by having different or lower cost shares if you use mail order. Though UMP does not have any sort of incentives. There's no carrots or sticks in UMP. Some places have carrots, and then in Kaiser there is this mandatory after your first fill and then your second, where you've learned more about the first fill program. And that's statewide, regardless of whether it's Kettle Falls or Seattle. But obviously there are important rural implications, as the Johnsons have expressly noted. But I did want to be clear that it is a statewide program.
And I want to assure the board that the staff are in communications, and they are absolutely aware of the issue and moving forward with looking at what needs to come back to the board and what actions need to be taken. I see that Elliot has her hand raised. Elliot, go ahead.
Yeah, so you mentioned something that sounded really interesting. When Aruna suggested that there be another open enrollment, and then, I understood the IRS implications that were mentioned, but you said this could be done. I'm not saying we vote on this now or anything like that, but you did mention that changes can be made without having a new open enrollment period. And can you be a little more, I'm not saying just in general what's happened in the past, so that you don't have to open up a new open enrollment period.
So Elliot, anytime that there's a situation like a member has a special open enrollment, there's a birth or death in the family, a marriage, a divorce, those all can trigger the ability to make a prospective change under the IRS rules. But the implication of that change can be very profound, especially depending on when it happens in the year. So let's say that and the IRS even limits the nature of the types of changes that you can make. It has to be related to the life event. So sometimes you're allowed to switch carriers, other times you're not allowed to switch carriers, but you can change plan designs. You might be able to move out of a high deductible health plan into a plan that doesn't have a high deductible. There are a lot of rules about what exactly is the relationship and nature of the event that is causing the change, but all of those changes are prospective in nature, and under our program, they're all prospective the first of the next month. Let's say that there is a scenario, and I'm afraid if you ask me for an example, I'm not going to be able to think of it right now, but let's say there's a scenario where I have a special open enrollment event and I can change actual carrier plans. If my event happens today, April 13th, and I make that change effective May 1st, the very nature of switching from one carrier to another means any deductible progress, out-of-pocket maximum progress that I made in the first 5 months of this year doesn't count, or 4 months of this year doesn't count. I'm rebooting all of that. So imagine that the special open enrollment happens in January. That might not be as burdensome as if it happened in November, when you've already reached all of your accumulators. So there's a lot of implications, and the IRS really does have a lot of strict rules. So sometimes there are possible changes that can be made. They're almost universally prospective, and when that happens in the year, can have those profound financial impacts, as well as the IRS limiting the very nature of the type of change you can make.
So, and I want to clarify something, Elliot. The board does not we don't vote on issues that aren't publicly disclosed and made available in a process. So we would never take action today. All these public comments get rolled into things that have to come back to the board or deal with in the future. But again, for the members of the public, we can only act according to our processes, and we don't take immediate action. So I'm not hearing or seeing any other comments from board members. What I'd like to do at this point is close out. I will remind you all that the 2023 board session schedule is posted on our website. It's always part of every briefing book, which is normally posted to the website the Monday before each meeting. Staff have been really trying to maintain that schedule. Sometimes there are little challenges with power outages or whatnot, so we ask for a little bit of virtual grace every now and then, but that is typically what we strive for. Our next meeting is May 11th, 2023 from 9 a.m. to 1:30 p.m. with this same format. And we really encourage folks to come and be in person. Of course, if it's easier, you can be present in Zoom. You're seeing we are trying to accommodate that as best as possible. I will note that it is likely that I'll have a delegate, my deputy, Lou McDermott, chair the next meeting, as I will be involved with some other state matters out of country. Dave, are there any final comments before we adjourn?
I always like to do a preview of coming attractions for the next meeting. Obviously, the legislature will be out of town, and so we will know what all bills have passed. The governor will have acted on some of them, but not on others. But there'll be Tanya and Cade doing updates on both the budget that has passed the legislature, and Cade's going to start diving into some of the implementation aspects of several of the bills. And of course, Ellen will be back. Ellen will be a staple of all of our meetings until she retires, which I'm never going to allow. And we know that right now we're working diligently to try to bring back the information related to public comment from Linnea Mulder earlier this year on pharmacy. So those are just a preview of some of the things that we know are in the works. Sue?
Thank you, Dave. John, I see your hand is up. I don't know if that's, but it also says.
I have a question. Do we record these meetings?
Yes, John.
Yes, John, and we post
them. Are
them
recorded and posted.
Yep, we post them. Our goal is to post them within a week of the meeting, and they're posted on the public website, where we also post the board materials and the minutes after they're passed by the board.
A lot of great information about Medicare. I wanted to go over that again, so appreciate that. Thank you.
Yep, it should be up within about a week, John.
Dave and your team, thank you for always assisting and making our board processes so smooth. Members of the public, thank you for your commitment and patience and involvement with us. Board members, we'll see you soon. This meeting is adjourned.